Good afternoon, everybody, and welcome back to our conference. I'm delighted to see with so many people have joined us this afternoon. For those who are coming back after lunch, I hope everyone had an enjoyable break and got something to eat and a cup of coffee. And for those who are joining us this afternoon, I want to welcome you and I hope you'll have a really interesting and enjoyable afternoon. I just want to draw your attention to a couple of things. You'll have seen the slide about the Zoom guidelines for our conference this afternoon. Secondly, to continue to engage in questions and points of interest. If you'll raise them through the question and answer function, that would be really helpful. Thirdly, to promote the conference and to the sessions you might be enjoying this afternoon through our 2 conference hashtags, which you'll see in front of you. And also I should mention, we'll be engaging in an evaluation of the conference, which we'll be sending out, if not this evening, tomorrow. And again, we'd be very keen that people would join in the evaluation and participate as much as you can. So building on our conference session this morning, where we looked a lot at the experience of children and their families living with ABI, this afternoon we're looking more at the experience of young people and adolescents. And to set the scene and to give us a very, I think, very timely presentation this afternoon is Gerard Anderson. And Gerard's the head of brain injury services within the Child Brain Injury Trust. Gerard will be known to a lot of us, and I've been very pleased to have the pleasure of working with Gerard over the past couple of years and delighted at how Gerard and our colleagues within Brain Injury Matters have worked very well together over the past while. Gerard, it's a pleasure to see you and really looking forward to your presentation. So without keeping you back any further, I'll hand over to you, Gerard. Thank you.
Thank you very much, Joe. I just wanted to pick up on just listening to the speakers from this morning and reflecting on why we're here and hearing from families over lunch. It really brings it home and focuses us in why we're here and the difference that we're trying to make. And we're here to make a difference for families and children affected by childhood acquired brain injury. And I hope by the end of today, listening to all of the speakers and families affected by brain injury, we'll hopefully achieve that. So thank you very much. Let me share my screen. Sorry, I'm just trying to share my screen here. Can you see that okay?
Yes, Gerard.
Perfect, thank you. So thank you very much. Thank you, Joe. As I said, over the years, services have evolved and developed, meeting some of the needs of families.
Sorry, Gerard, sorry to interrupt. Your slides have just dropped off the screen there. Do you want to just hit the green share screen button again, if you can?
Yeah. Okay.
That's you, and then full slideshow from the beginning, and that should be you. All good to go.
Perfect.
Thank you.
Thanks very much. Thank you. As I'd mentioned, over the years, services have evolved and developed to meet some of the needs of families affected by childhood acquired brain injury. But no one's really anticipated how these services would evolve in the middle of a serious incident, or what services should look like for the emerging needs of families. So what I want to explore is how services have developed in Northern Ireland over the years, as well as how they interlink and connect with one another to help the child and their family achieve their rehabilitation goals, but also taking into consideration the coronavirus. So across each trust, there are specialist teams that are set up to meet the needs of adults with acquired brain injury, but there's no real specialist service similar to adults that focus on pediatric acquired brain injury. And much of the support is left to centralized services or pan-disability services, and quite often community and voluntary sector organizations. Now, the Cedar Foundation, one of the oldest charitable organizations in Northern Ireland, it was set up in 1941 and incorporated in 46, started as one of the first charities to help children with brain injury, not specifically ABI, but also included that. But it wasn't until 1999 when the next regional charity started providing services, but this was through Headway, but they weren't pediatric services. And it wasn't until the Child Brain Injury Trust started providing support in 2001 through small support groups and then became a commissioned service in 2004 that the next services became available to children across Northern Ireland. And it was a long time since CEDAR began providing support, but again, it was limited in capacity to fully meet the needs of families. So this meant that there was only really 2 charities across Northern Ireland at the time that were able to meet the needs of children and families. And that was for many decades until Brain Injury Matters began providing support to adults with brain injury and then expanding their services to support children and parents, which we've heard a lot about today, to meet those needs. But there's still limitations in capacity, there's limitations and resistance to integrated services, and a lack of investment in pediatric services as a whole. And this is not just in brain injury, although there are a number of reasons for this. So whenever we consider the needs of families and how to accurately assess, firstly, the prevalence of pediatric acquired brain injury in Northern Ireland, and secondly, the support needs of families across Northern Ireland, there have been limited but accurately consistent assessments and conclusions made. In 2011, Dr. Mark Linden, Claire Lundy, and Bob Taylor accurately assessed how difficult it was. Firstly, to record the prevalence, which was partly due to how injuries were coded, but secondly, the gaps in coordinated discharge plans and focused neuro-rehab plans, which there still needs to be ongoing work around, and both of which can impact the promotion of positive long-term outcomes after acquired brain injury. Now, since then, we've had the RQI review into brain injury services in Northern Ireland, and that was in 2015. And although UK-wide and not focused specifically on Northern Ireland, the all-party parliamentary group Time for Change report on brain injury services, but it still identifies similar themes that still impact children and families in Northern Ireland. And some of those themes we've heard about today, and they cover education, rehabilitation, both physical and cognitive. And what's very important and topical at the minute is the psychological and emotional rehabilitation after brain injury. But what I'm glad to hear about is the importance of support for the whole family, not just in acute care, but through the continuation of care and to improve outcomes overall. So now we're in a position where a further review of neurology services is in place, and it's great to see the Brain Injury Matters review and report. Now, the neurology review has been tasked with identifying the optimal service configuration. That's the term that it uses for neurology services through to 2035. The issue that we have is that there's no rush to implement services. We're in the middle of a global pandemic and with issues with funding, capacity, workforce, and some concerns with the level of buy-in from on-the-ground services and teams. If we don't have key services involved in a Northern Ireland-wide review of neurology services in Northern Ireland, then it's still going to be difficult and left to existing limited support networks to provide that support across Northern Ireland. So where are we now? These are support teams and services within the community and voluntary sector that are able to provide some of the brain injury support across Northern Ireland, but not all of these are paediatric support services. So there's still more to do and still a lot further to go. But now we have an additional challenge that presents a new hurdle. So we've got a journey like no other. We're now in a position where families are faced with a journey like no other and a challenge that they haven't faced before. It's now just been over a year since the start of the coronavirus pandemic, where on the 11th of March 2020, the World Health Organization declared the virus a global pandemic. And 1 year on, COVID-19 has led us to an unprecedented challenge in public health across Northern Ireland, but even more so for children and families with additional support needs, and for us specifically acquired brain injury. And this isn't just a challenge for primary care services and acute services, but community services that provide therapy and rehabilitation post-discharge from hospitals. Whenever we speak to parents, one of the things that we make them aware of is that they're going to become project managers. And it's not something I like saying, but it's a reality where parents will need to coordinate a lot of the support that their children or child receives. But at the end of 2019 and 20, this term was never more truer. With remote working, childcare, in-person and virtual appointments, both in the hospital and in the community, and neuro rehab being coordinated by parents with limited support or none at all. This is made even more difficult whenever you consider that the majority of young people with acquired brain injury primarily have cognitive support needs. So there's a limited number of young people with physical disabilities or support needs. So quite often they don't meet the referral criteria for a lot of community services, which again is left to the project manager or parents to coordinate. And more often than not, the project manager within most families is a person who takes on the maternal role, which during a recent Child Brain Injury Trust survey was confirmed, and that was with 80% of respondents being mothers. And whenever we consider the impact that a project manager or parents have on the rehab journey after acquired brain injury, working as a team couldn't be more important. And that's something that's come through in the themes today as well. Whenever we become parents, there isn't a manual that tells you what's right and what's wrong. We have to rely on intuition, we have to rely on instinct and support from our network. As has been mentioned with Bronfenbrenner's Ecology of Human Development and this ecological model. But whenever you have a child with additional needs, the support from others is even more important, as the strain can feel even greater. And whenever we consider the support needs of parents, getting it right at the beginning of the journey is where the scaffolding happens. And that's where working as a team has a massive impact on long-term recovery. So as health professionals, this begins whenever you reflect on what engagement really looks like and whether or not you tell a parent what is happening, or if you explain to parents what's going to happen, or whether or not you truly engage and co-produce rehabilitation services after acquired brain injury. Now, all of us understand the difference between gold standard care and the reality of services, but how many of us really work with parents and carers to help them understand and navigate the reality of acquired brain injury? So whenever we think about how we engage with parents and carers and how many of us work with the wider family, how often do we consider the siblings? We have young carers groups in Northern Ireland, and we have some great services across each of the trust areas, but not a lot of research has been done around this. What often happens after a child sustains an acquired brain injury is that siblings often become young carers. And this is a young boy called Kamani. I was talking to Kamani and his mum just before this presentation, and he was very excited at the thought that there was over 200 people going to see his presentation. And this is for people to remember that brain injury doesn't just affect the child with ABI. Whenever a child becomes a young carer, it can impact engagement levels in school, peer relationships, it can impact mental health, and it can also impact stress levels of siblings. And children are intuitive, but they also take on the stressors of other family members, and more often than not, internalize those anxieties, which are then externalized in other ways. So as parents and carers, we often try and shield siblings from the reality of what's going on. But if we were to consider how we could involve siblings in the recovery journey, it may improve anxiety levels, it could improve engagement with peer groups, and it could promote positive long-term outcomes for not only the siblings, but the child with the acquired brain injury and other family members as well. So we've thought about parents and carers, and we've also looked at the support needs of siblings. So what I want to talk about now is the young person with the injury or illness. More often than not, we can't control what's happening around us, but we can control how we react to any given situation. And that's how we hold on to control when it's out of control, and that's how we manage different situations, by trying to control what's within our grasp. But what happens whenever, along with not being able to control external factors, you're also unable to control internal factors? You have a feeling of losing control and you fight to try and create some resemblance of order and to try and hold on. So think about, are you telling, are you explaining, and are you co-producing? It doesn't just apply to parents and siblings, but it also applies to the child with a brain injury, especially in that acute environment and that early stage of recovery. So an analogy that I heard used by a very well-respected person in the regional acquired brain injury unit in Musgrave Park Hospital was whenever he was referring to our brain as like a filing cabinet, and everything we say and everything we do is in the right file, in the right order. And a brain injury is whenever all of those files are taken out, thrown on the ground and messed up and put in the wrong order. And the rehabilitation journey is putting those files back in the right drawers and in the right sections. And that time period can take days, it can take months, or it can take years, and some of those files may never go back in the right place. And that's what happens with rehabilitation. Now, how much easier would it be to reorganize that filing cabinet if the person who owned the filing cabinet and owned those files had some say or was able to help you with it? And that's where co-producing and engaging with young people and the family around the child can make a big difference. So there's a lot of considerations when planning this and strategies that can be used both in an acute environment as well as in a community environment. But engagement and co-production are two of the most important considerations when planning these things. Now, that said, there are considerations that should be given that not just impact recovery and rehabilitation, but prevention. And to do this, we need to put the right support in place that considers risk factors that can potentially lead to sustaining an acquired brain injury. So whenever we talk about risk factors, it's important to note that it doesn't mean that if these apply to you, that you're going to end up with a brain injury, or that this is the reason why you have a brain injury. It does, however, mean that there are certain risk factors that should be considered whenever it comes to raising awareness and developing preventative measures that can reduce the incidences of sustaining an acquired brain injury. And these are some of the areas that awareness raising should focus on. So we know that the following risk factors apply. And if we're looking to reduce the incidences of brain injury, awareness campaigns and consideration need to take this into consideration, especially around adolescents and under fives for different reasons to do with brain maturation, developmental cycles, and with young children falling. Now, whenever we think about preventative measures and when they don't work, the first stage of support is usually whenever the injury or illness first occurs, and where appropriate support and scaffolding is key. And for the majority of children and young people, this happens in A&E or across the country, primarily begins quite often in the Royal Belfast Hospital for Sick Children. And for most of those children that we work with as brain injury services, it occurs in the neurosciences ward in Paul Ward. Now, as a parent or even a young person with an acquired brain injury, hearing these first lines is not new if you work in a hospital. If you're a professional that's worked in a hospital, you may have said them, or you may have heard other people say them. Sorry, I don't work on this ward. I'm not sure. I'll find someone for you who can answer your question. And one of the big lines that a lot of families hear is medically fit for discharge. Medically fit for discharge means that there's no longer a need to continue your care in an acute environment. It doesn't mean that your journey is over. Quite often your journey is just beginning. So as a parent or even a young person, hearing these words has a massive impact if there's no one to support the family at this acute stage to help them understand the language, who to ask for, where to get water, knowing who the right nurse is or who the ward manager is, or even the sister in charge, and that these rules can change on a day-by-day basis. So it's a very confusing environment ordinarily, but adding in all of these intricacies and changes, it makes it even worse. And this is where Paul Woolard has been developing services by working with community and voluntary sector organisations, Brain Injury Matters and the Child Brain Injury Trust, to support that discharge from an acute environment and linking in with community-based services. Now, it not only helps manage the support needs of families in an acute or hospital environment, but it supports that discharge and integration into community services and back into education, which, as we know, is a key area for rehabilitation after brain injury. And that's where the social work team and psychology team have been doing a lot of work alongside Paul Ward. So we talked about gold standard care, and some of the most important pieces of information and important documents that are underestimated are the hospital discharge letter, and if a family is lucky enough to get one, a rehabilitation prescription. And what is key alongside these documents is to set manageable expectations around access to support, the importance of family input in rehabilitation, and ensuring that the right support is set up. But it's also important to make sure that this is set up when creating the scaffolding that I talked about around the family, and preparing the new project manager for what is needed to effectively rehabilitate an injury or illness. And that's where it's important to differentiate between the terms recovery after brain injury and rehabilitation after brain injury, which Dr. McCrudden talked about earlier this morning. So this is the journey ordinarily, but what should or does it look like if you throw in a global pandemic into the mix? When services are already stretched, wards are converted to COVID wards, and staff are redeployed to adult or COVID wards, and services are suspended. From court hearings to GP appointments to education, social services, the coronavirus has had a huge impact on the way public services are delivered. And we already know that there's a lack of access to specialist paediatric brain injury services, and the integration between children's services and adult services in some trust areas is already inconsistent. But within hospitals and within community rehab services and social services, what happens whenever those services are stretched even further? So there's been a lot of research on the impact of COVID-19 and the impact on recovery post-illness and injury. And research will continue for many years to come, we know that. But the impact on neurology services due to injury and presentation, as well as how comorbid conditions are linked to neurology, is inconsistent as well. And that was lightly touched on by Professor McCusker. And where additional research for our families is very important. Now, the review of neurology services is going to be key and important for this, as well as the upcoming survey from the Neurological Alliance on Neurology Services. But much more is needed, and why in 2019 we carried out a survey on the impact of COVID-19 with families that we support. Now, we know that neurology services have been negatively impacted, from appointments to routine and planned procedures and operations. But what we didn't expect, which has been expedited by support, is that years of innovation at times is taking place in a matter of months, with many of the most successful changes developed locally and by frontline staff. And this is something that we would like to continue. So in 2020, the Child Brain Injury Trust carried out a survey with the aim to assess the direct and indirect impact of COVID-19 on families affected by childhood acquired brain injury. And this was to understand the social, emotional, psychological, financial, and rehab impact of the current lockdown, which aims to assist in the development of services, work with other organisations, and support networks for families affected by childhood ABI. So over half of all respondents who responded to the survey identified that the support needs they had from the Child Brain Injury Trust was as a direct result of the current pandemic. However, at the time the survey went out, only 6.78% of children and young people with an acquired brain injury suffered symptoms of COVID-19. I know things have changed more recently. Unsurprisingly, the mental health of families affected by childhood acquired brain injury has been significantly affected by the lockdown, with 56% of respondents accessing support for mental health and well-being. And I know that aside from the Child Brain Injury Trust, Brain Injury Matters and other organisations have counselling services which are addressing this. And this coincidentally impacted the number of referrals to our service. Over 62% of respondents have had appointments or procedures cancelled. And unsurprisingly, which has been mentioned a lot through today already, education support has been significantly affected by the lockdown. And this is something that we've noticed nationally as well. Nationally, we've noticed and talked about how hospitals and community staff have been redeployed. We know that paediatric wards in some hospitals have been converted to adult COVID wards or paediatric COVID wards. And we know that elective procedures have been paused or cancelled, and that this is not only placing a lot of pressure on hospital teams, but community teams and community services as well. So what does this mean for families in reality? We know that the word gold standard care doesn't exist in reality. That was actually accidental misspelling that, but it worked out really well. In reality, this is something that we strive to achieve, but unless there is massive investment, it isn't possible. We know that when services aren't available, especially if stretched at the best of times, it can impact on rehab potential. So what this means for community services is that we have to think of innovative ways of providing the best care possible, and where we now have digital and virtual rehab being delivered. But again, we don't know the full impact this is having on rehab potential with some types of rehab. And this is where we need to think about the importance of the project manager that we talked about, involving the whole network, the ecological model, and the importance of communication in creating a proper scaffold, which we talked about as well. And this is even more important whenever we consider the impact acquired brain injury has on the family. Then add in the impact of COVID-19 on a family with a child with a brain injury. And it's not just one family member who climbs the recovery mountain. We know that the mental health and well-being is impacted, which can impact how we react and the support available to manage psychological recovery after brain injury. And where recovery often happens and what has been significantly impacted has been education, and where we may not know the full impact for a number of years to come. And this doesn't just go for education of the child with the acquired brain injury, but the educational attainment of siblings, whenever we consider their role as young carers. And what we all also know often impacts families are finances, and where putting the right support at the beginning can make a massive difference, especially in working with third sector organizations. So we know the social, emotional, and psychological impact of childhood acquired brain injury on a family ordinarily. And we know the impact it's having during a COVID pandemic. But what does this mean for recovery? On discharge, the real journey begins, and how that support network is put in place can make a massive difference to the trajectory of recovery of a child with a brain injury. But how often do we get it right? Do families know how important a discharge letter is, or how important a rehab prescription can be when it comes to collecting evidence for assessing services and support, which coincidentally also depends on how well they're written and who they're written by? How often do parents, siblings, and children co-produce the discharge plans and feed into discharge planning meetings? And what impact would this have on recovery post-acquired brain injury, especially at the minute in the middle of a global pandemic? Now, it would potentially impact recovery in a positive way. It would impact protective factors around the child, siblings, peer groups, education professionals. Now, the last slide, I can see Joe coming in there, is what does it mean for future services, both the review of neurology services and recovery after acquired brain injury. We know that workforce is an issue and something that won't change quickly. We need more neurologists, specialist brain injury nurses, outreach clinics across the trusts, and parity with adult brain injury services, but this is going to take time. We also know there's a big gap in access to and referrals to neuropsychology services, with most children and young people having to go to Belfast for specialist follow-ups. But whenever considering the services we already have access to in the community through CEDAR, Headway, Child Brain Injury Trust, and Brain Injury Matters, and the Children's Acquired Brain Injury Consultation Service, we need to continue to share good practice, which is what is happening today. We need to develop current opportunities, which again is happening today, and acknowledge the challenges that there are and create a scaffold for families and other professionals around that child that promotes positive long-term outcomes that then enables us to remove the scaffolding surrounding a family. Thank you.
Gerard, thank you very much. Again, really helpful and very comprehensive presentation. I thought it was great to put our work, collective work in terms of the voluntary community sector into that historical context as well, and setting out who does what and where and why. That's very helpful. I think the emphasis on co-production, and you've highlighted very clearly the role of the family and siblings as well, I think is a key part of this as well. I suppose again, it's not, I will put you on the spot a wee bit, because your last slide I thought was really helpful in terms of setting out what you feel are the needs of services going forward, and you use the word investment. I suppose, I mean, and again, you have the advantage of working across the UK and bringing across that experience. In terms of Northern Ireland, if you had, again, a magic wand to wave, Gerard, where would you put your investment? What do you think would make the biggest difference and impact on services, ABI services, for children and young people in particular?
There's a number of points that have been picked up on by a lot of people today, and themes which are reassuring but also concerning. One is education, which is great to see the Education Authority and the Children's Acquired Brain Injury Consultation Service setting up work around training. Education is key after rehabilitation post-acquired brain injury. Not just physical rehabilitation, but cognitive rehabilitation. And aside from education, psychological and emotional support, because not all of the support needs are necessarily to do with the brain injury or the insult to the brain. It can be around psychological and emotional rehabilitation and support needs. And that's where there's limited investment in neuropsychology services, in clinical psychology services, in each of the 5 different trust areas. But also the importance of bringing, and this is an easy fix, bringing the family into the rehab journey and ensuring that the family have say in how that rehab journey looks, and bringing families on board whenever children are first discharged as part of an equal member of the MDT or discharge planning meeting. But key is education, investment in psychology services, because they're already overstretched. And there's so much potential with the Children's Acquired Brain Injury Consultation Service and psychological services, but the investment there has not been made significantly enough.
Gerard, thanks very much. I know that was a difficult question to answer, because probably you and I could come up with a list as you have of areas we'd like to invest in, but I really appreciate you taking that question, and also Gerard for your presentation. We're obviously very happy you're staying with us for the rest of the day. So thank you, Gerard, and we'll catch up with you later. Thank you. Thank you. I want to move on then to our next speaker this afternoon, who's Suzanne Turner, who is from the Youth Matters project within Brain Injury Matters. Gerard and others today have referred to the work with young people and adolescents, and that gives us an opportunity now to hear more of the work that Brain Injury Matters is doing through Suzanne and the team, sharing her experience of working with adolescents, the challenges and the learnings from that. So I'll hand over to Suzanne. Suzanne, lovely to see you, and look forward to hearing from you. Thank you.
Thank you, and just bear with me 2 seconds, and I'm going to share the screen. There we go. Well, thank you so much for joining me. So I'm Suzanne, or Susie, as I'm probably better known by most. So I'm a speech and language therapist working on the Youth Matters Empowerment Programme. So I would work with our 13 to 18-year-olds across Northern Ireland. So in my role, it's very much to support the whole family unit, but actually a a lot of my colleagues today have spoken very much about that family work. So I'll be discussing a bit more in depth about how I work very closely with the teenagers themselves, both on a one-to-one basis and in groups. So I'm going to chat to you today about how empowerment really is integral to engaging the young people in our services. So there we go. So this is just a brief overview of what I'm going to cover in this talk today. Also, if you hear that noise in the background, I do live beside a train track, so apologies, that is the extra noise. So overview today, going through what it's like to be a teenager. Again, no one size fits all, but we're going to chat a little bit about some considerations of what it's like to be a teenager, then to consider that in the context of what it's like to be a teenager with an acquired brain injury. I'm going to take you through a short story, a day in the life of, and then we're going to look at how we really put that into practice on a one-to-one basis and in a group basis, and then I'll follow that up with some of the challenges that we face. So first of all, I'm going to ask you to think back to your own experience of being a teenager. So as I say, we work with 13 to 18-year-olds. So thinking back what it was like at varying stages throughout your own adolescence. So 13 versus 15 and 18. And it's a really simple exercise, but it's something really useful in terms of gaining perspective and empathy of what's really going on for our young people. I'm thinking of the kind of decisions that you were trying to make, the choices you were trying to make about your future and your life, maybe the different pressures, the type of independence that you had, or the type of independence you wanted but didn't have. And as I say, while no two teens have the same experience, there are some common elements and some common themes that you may relate to that may be similar to what some of our young people are experiencing. So the likes of physical changes, hormones, experimentation with their style or identity, increased self-consciousness, maybe an interest in relationships, choices about education and the future. And that would be a very big one with a lot of young people I'm working with, making decisions about what to do, you know, to go to university or to stay on at school or to go into work. And also the skills involved in, you know, applying for these things. So learning how to fill in an application or to write up a CV. So now that we know, you know, it's not easy being a teenager by any means. It can be a really difficult and confusing time. But for somebody with an acquired brain injury, it can come with a lot more challenges. And I know it's been mentioned a few times today already that it really can be a hidden disability. So a lot of teens with an acquired brain injury may appear the same as their peers, but they may have a range of difficulties that really impact on their day-to-day functioning and their ability to manage all of the associated pressures of being a teenager with an acquired brain injury. So many of these include, you know, memory difficulties, cognitive difficulties, communication difficulties. So say, for example, a lot of the young people that I would be working with actually would struggle with quite abstract language. So they may struggle to understand sometimes what's being asked of them, whether in class or at home, in exams, or when filling out applications. And this can be quite a subtle difficulty that's not easily picked up. There can also be physical difficulties, things that we actually may take for granted, like the ability to put clothes on or put your hair up or something like that. There can be emotional and psychological difficulties following acquired brain injury, and behavioural difficulties, fatigue, social difficulties and isolation. And there can also be just a plethora of ongoing treatments and other services involved. So it can be a lot of things for a young person. So before I take you through some of the specifics of how we support a young person with an acquired brain injury, I wanted to take you through an example. So I'm going to take you through as if this has been written by Kyle. So this is very much based on conversations that I have had with so many of the young people on our service. Okay. So 7 a.m, the alarm goes off. Surely it's not time to get up yet. I only got to sleep around 12. Mum told me to go to bed at 10, but I stayed up. I was scrolling through the social media. I'll just hit snooze again. The alarm goes off, but I'm so tired. Mum's calling me now to take my tablets. She always has to remind me to take them. I'm meant to do physio in the mornings, but I can't be bothered. I don't see the point anymore. It's not working. Mum is rushing me. She has to drive me to school these days because I haven't been able to get the bus since my accident. So we have to leave earlier. Everyone is stressed in the mornings, including me. I'm dreading today. I've not made any friends in this year group. I can't believe I'm now in my younger brother's year at school. I feel really embarrassed. I miss my friends. They don't talk to me as much anymore. I tried texting them, but I didn't really know what to say. It's like my mind goes blank. They look at me like I'm different. I see pictures of them all the time on Instagram doing things without me. I hate being left out. What if no one ever talks to me? I'm in school now. I feel stressed walking through the corridors. There's so many people, so much noise, so many lights. It's really overwhelming. I'm a bit slower walking now and I feel unsteady on my feet when people push past me. My teacher shouted at me again for yawning and putting my head on the table. I'm so tired. I didn't mean to be rude. I also forgot my homework again. My classroom assistant is a nice person, but I wish she didn't have to be here. No one else in the class has an assistant. It's home time and I'm exhausted. I have another appointment to go to after school though before I do my homework. Which one is it again today? Speech therapy, OT, physio, maybe it's psychology. It's hard to keep up. I'm really tired. So as I mentioned, this was based on many conversations with young people. And it isn't reflective of all young people within an ABI, but it does highlight many of the different challenges that would occur throughout the day that just compound the challenges of getting through day-to-day life. So these are some of our key considerations when it comes to empowered engagement. So really building that rapport with the young person, making the sessions engaging and fun and building trust, really actively listening, recognizing that it's important for that young person to have a space to be seen and heard and to really share their experiences without judgment, accepting them for who they are and meeting them where they're at. And also the autonomy is such an important thing because for so many of our young people, they don't have a big say about what's happening to them on a daily basis. So for any young person on the service, we really take into consideration as many factors as possible. And we really aim to collaborate with that young person for as many opportunities for autonomy and responsibility and giving them the chance to make their own choices. And we're also very aware of the differences in power dynamics in any type of therapeutic relationship and the impact that this can have on engagement. So we try to minimize that imbalance and really co-produce as best as possible. So even reflecting back on what Gerard mentioned around, are we telling them? No, so we don't have that prescriptive approach of like I say and you do. We are really flexible in our approach and try to engage the young person to make their choices and empower them to be that agent of change. We're also really flexible in our approach. So for example, one young person I've been working with struggling with fatigue and concentration. So we started off with just 15-minute sessions and we have slowly then built up to from 15 to half an hour and then right up to an hour. So we also then provide services after school. So that's another element of that flexibility in terms of supporting the family so they don't have to take more time away from class. And we scaffold them as well. So we are sort of maybe providing more support in the beginning, and then we gradually reduce the need for that. Okay. So how do we put this into practice in a one-to-one setting? Well, we really work to help that young person with their own self-identified goals alongside the goals of the family unit. So for example, that might be around improving confidence in peer interactions or improving engagement with education, supporting with routines. Morning routines is a particularly common area that we would work on, and helping to plan for the future. So this might look like explanations and information about acquired brain injury, education about issues that can occur following an acquired brain injury, such as grief and loss, behaviour and sleep. And just on sleep, so for example, one young person that I was working with was unaware even of the impact of caffeine on sleep. So he wasn't getting to bed until, or getting to sleep even until about 4 a.m. and managed to get this back to around like 11, 12 after reducing from 4 to 5 energy drinks per day, as well as cups of tea and coffee. So just some of that education as well around lifestyle factors. We provide emotional support to parents, young people and their siblings. And actually in terms of supporting a sibling, so for example, one young man I was working with, his younger brother had been getting into a lot of trouble at school, and this had come on quite suddenly. And we did a little bit of one-to-one work, and through that we were able to identify that he was feeling left behind and sort of not seen, and this was his way of getting some attention. And it was a really supportive relationship then. He felt like he had somebody that he could talk to and vent to a little bit, and because he was finding it difficult, he was finding it unfair that his older brother was now perhaps getting away with more than he was, and he felt that he had maybe had to take on that role of the older brother. So that in that way we would work as well with the siblings to support their adjustment. Other ways in which we support in that one-to-one are through revision and memory techniques. So this could be the likes of personalised schedules, timers, taking restorative breaks, a lot of prompting and getting the young person used to building prompts in their own environment or, you know, on their phones. So for example, one technique that has worked really well with quite a lot of the young people is recording revision or you know, notes from school onto the voice notes on their phone. And then this is another way in which, if they're really fatigued or tired, they've been on Zoom all day. I mean, a phrase that I hear very often from the young people is, I'm all zoomed out. So this is another way where they don't have to actively, you can keep their eyes open, they can listen to their notes whether they're lying down or they're going for a walk. And it just helps them in this other area of being able to learn and manage fatigue. We also use tools such as counselling skills and motivational interviewing techniques to really help that young person to take a more active role. So one of the one of the underlying things within motivational interviewing is they say that you want to make the person a little bit itchy so they want to scratch. So you're wanting that person to kind of realise that they maybe do have some options available to them to change. So for example, I've been working with a young man who really didn't like his job, and when we started chatting about it, he hadn't looked up any others, and he wasn't really exploring any other options. So through some problem solving, he was able to then set aside that he could work, you know, he could look up jobs for half an hour on a Tuesday night when he came home from work. And from that problem solving and getting him to kind of become that, have that inner motivation to change, he has then written his CV, he signed up to a recruitment agency, and it looks like there may be some other options on the horizon for him. So that is one way in which we would work with the young people, to help them to identify some of the solutions that are available to them. Another way in which we problem solve, another example would be a young man I was working with who would get into quite a lot of physical and verbal fights with one of his brothers. And he found it very difficult to sort of calm himself or self-regulate if he became quite angry. And he had struggled over the years to implement techniques. And he said that he was too embarrassed to do deep breathing techniques. So one thing through problem-solving discussions we found that would work for him is when he felt himself getting angry, he would take himself off to the bathroom and then just run the cold water over his hands. And he found that this was a really sort of viable option for him because it was transferable to school as well. He didn't have to, you know, try and dialogue with himself, and he didn't have to try and do the deep breathing, which he was embarrassed to do in public, but he was able to kind of take himself off and let himself, you know, regulate. And this running the hands under cold water became a cue for him to kind of then breathe when he was in the bathroom, and then making sure to give really consistent feedback to the young people. Other strategies then in terms of self-care we would support young people around relaxation, mindfulness-based thinking, and then strategies to deal with stress. And recently we had 2 young people who made contact to say that they were having a particularly stressful time and asked if they could set up appointments to discuss this. And I just thought that this really demonstrated that those young people felt empowered, that they could contact somebody, and about that level of rapport as well, that they knew that there was support available to them. And while often the advice includes advice and strategies, it can often be lifestyle based and around hobbies and helping young people to connect with other people. So for example, one young man I've been working with is feeling very low and sort of directionless in life, frequently having quite angry outbursts, and through discussions of interests, turns out really loves fishing, and he felt like that would be a realistic goal would be for him to start fishing at the weekends. And he started this in around January time, and I actually had a session with him last Tuesday, and he informed me that he is applying for a fishing apprenticeship, and he has been going fishing multiple times a week. He's got some friends involved, and he has found that he just feels so relieved now that that is his primary stress relief technique. But it's also now something he's been able to merge with a potential career path as well. So that's a really lovely outcome for him. We also then really work with other services and agencies on a collaborative approach, and we link in with the likes of GPs and schools. So recently I would have had quite a lot of contact with a GP and a school in relation to a young person who has been struggling with a lot of exam related stress. We also signpost to other agencies as required, and for example, one young person, I was able to support them to acquire some funding for rehabilitation equipment, which has enabled them to participate in their A-levels, and will often then support the young people to create routines that support them as well. Okay, so we also have, in terms of empowering young people in a group setting, we created the youth steering group. So it's made up of 3 young people with an acquired brain injury, and they really help us to shape the delivery of the youth activities, taking into consideration the perspective of teens with an acquired brain injury. So we have a chairperson, a secretary, and our lovely treasurer, Roisin, pictured there. So the young people have been involved in the planning and decision making related to our youth events, such as our games night, and we have our little invitation here to our upcoming bake-off. So the young people have been empowered to let us know as well when a particular activity that we were running in a sort of short series, it didn't really go as anticipated. It wasn't as fun or as engaging as as we thought it might be. So the young people were supported in the decision not to continue with that activity, and instead helped us to put on a family quiz instead. Another way in which we supported the young people, one young person had identified that there was a barrier to participating in online group discussions because they felt quite shy or embarrassed about, who speaks when, because we do on like Zoom calls, you get that sort of dreaded dance of, oh, you go, no, you go, oh, and then everyone's trying to talk over each other and somebody kind of misses out. So what we did was we made a template for the agenda. So we wrote this out in a really conversational way so that the chairperson could read it aloud, and then we would randomly allocate the order in which the young people responded by using their initials. So this meant that people knew when they had to speak. And although we still use this format, over time the young people have really reduced their reliance on the prompting and will now just offer their opinions more freely. So that's one of the ways in which we have really supported young people in that group type setting. Some of the challenges then, so children with acquired brain injury are currently managed by children's community teams, and at times there can be a perceived lack of knowledge and understanding of ABI. So at times children and young people don't meet the referral criteria due to the label of acquired brain injury. And there is this belief that services do not have the specialist knowledge or resources to support that individual. And we can find then that focus can be on the diagnostic label rather than the presenting issues of, say, memory or anxiety or sleep issues. Another issue that often arises is that if young people come to us and they haven't had a cognitive or neuropsychological assessment, that's not something that our service is equipped to offer. So this can delay our ability to know how to fully support that young person or the children or families. So we know that no two young people with an acquired brain injury present in the same way. There really is a whole spectrum of need, and that can range from mild to severe, and it can impact across all domains of function, you know, whether cognitive, emotional, physical. And a consequence of the children's community model of care is that children with a brain injury after discharge are not always under the care of neuroscience services. Also, as a charity, we don't receive any statutory or core funding. And so currently our remit is to provide a family level of service. But the reality is the majority of cases we are working with extend beyond family support provision, needing more therapeutic and skilled involvement. But due to lack of provision elsewhere and our skill and knowledge base, many of these cases are then referred in to us. Another difficulty is the lack of longer term support for young people with acquired brain injury. So we know that the impact of ABI can be lifelong and difficulties aren't static. So many people require support at different stages. So whether that was a transition stage or developmental stage. Obviously, as a charity, we have funding constraints, which mean that while we can provide intensive support for up to a year, the families can then remain in our online community and have access to activities, and they can re-refer, but we don't have the capacity to continually work with families or provide a sort of a drop-in service. And as with the majority of services, there are challenges. We don't claim to have all of the solutions, but I think it's just really important to reflect this, and that with better partnership working between health and education and the voluntary sector and the families as well, that we can all ensure that the young people and families of people impacted with brain injury can be supported to live beyond that acquired brain injury. So thank you very much for listening.
Susie, thank you very much. Really enjoyable presentation, and no worries, we hardly heard the train at all. Just a distant rumble in the background. And thank you for finishing on time, slightly before time. The disadvantage of that gives you an opportunity to take some more questions. So Susie, just reflecting back on what you were saying, you know, I suppose for all of us to try and remember what it's like to be a teenager. For some of us, that's clearly a long time ago. And then layering on top of that, the issues around having acquired brain injury, and your case study of the young fella, Kyle, I thought really, you know, brought that together. And one of the questions posed was, you work with a lot of young people. Firstly, how do they take to the label of being brain injured? Because it's a very difficult age, and putting a label on somebody like that. So maybe I just ask you to respond on how do they cope with that at the very beginning?
So, and I suppose, as with everyone, like no two young people will respond in the same way, but for a lot of the young people that I have worked with, there would be the sense that the label can be quite limiting, or there can be quite a negative connotation as to what that means. So, you know, having an acquired brain injury, especially when people then are worried about the future. So I know for a lot of the young people I've been working with, because they've an acquired brain injury, that maybe impacts on the potential to drive, or and what might be involved there. So that can be a real concern for young people. Other young people really can come to terms with it, but it does seem to be something that a lot of the young people would rather keep to themselves, and would very much not like friends to be aware of, or only for a small, you know, close-knit group to kind of know what has happened to them so that they can support them. But it is often a difficulty that young people carry themselves with their families, and don't necessarily share with their peers.
Yeah, thanks, Susie, because it picks up, I think, an example Ewan gave this morning in his talk about a young fella, basically saying he was going to tell his friends to, well, basically mind their own business, which I thought was very, very powerful, very empowered thing for the young man to say. Picking up on your experiences as well, obviously a lot of the techniques you do support young people with are very practical techniques. So I just wondered how you coped during lockdown, during pandemic, and also how do you feel that's going to influence this type of service going forward? And finally, it's a big question, you highlighted a lot of challenges in your last slide. Again, are there particular areas you feel that would be important to invest in to try and enhance and develop service? So it's looking post-COVID and maybe looking even a bit longer term than that, if you wouldn't mind sharing your thoughts on that. Thank you.
Okay, so in terms of practical strategies and how we've kind of dealt with the pandemic, I think there have been benefits of working remotely, and there have certainly been challenges as well. So actually some young people seem to have really enjoyed the sort of the virtual nature of the sessions, the flexibility as well. We've actually been able to maybe have sometimes slightly shorter sessions than, say, maybe your standard hour or more if you've traveled out to the family home. So that has worked. We've also been able to share screens, and so there maybe has been more opportunity for quite interactive activities. And with running our groups online, we have been able to bring together young people from opposite ends of the country, which has been really nice, because when we previously did have face-to-face activities, those young people wouldn't necessarily have met before. So that has been a real benefit. In terms of challenges, some young people haven't wanted to engage as much, and we have had a couple of young people where maybe haven't come along to the activities. And again, back to that phrase of all zoomed out, that they're spending all day with for school activities on Zoom, and to come on sometimes for whether it is a quiz or a games night, it can seem almost like another school task. So that has been a challenge. But I do think that there is a scope from the feedback that we've got for that blended approach, that for some people, for those it works for, there is that opportunity there. That's something that we can utilize going forward. But for those people who it has been more challenging, maybe that reflects that there is a need for that face-to-face intervention for some families again, and that need to bring back that connection in terms of activities. I suppose in terms of challenges then, and an area for more funding, I think education would be the one that, I suppose, particularly for the age group that I'm working with, and the exams, so GCSEs, A-levels, making choices about future, and for an awful lot of the young people, anxiety and stress would be kind of primary presenting issues, and often that is exacerbated or is related to the pressures within school, and how that is often not really their difficulties are not always necessarily understood in that context. So that would be the area that I would think that there would definitely be a need for some more support funding or understanding in terms of acquired brain injury.
Okay, Susie, thanks very much, and thank you for a really interesting and really informative presentation. We'll see you soon, and enjoy the rest of the day, Susie. Thank you.
Thank you.
Thank you. Okay, that takes us on then to our next presentation this afternoon, which is from Dr. Bernadette Salisbury and from Rory Keenan. Earlier on in the day, Bridget from Brain Injury Matters referred to our new pilot project working with the Southern Trust, which has allowed us to, as it was, develop a stronger relationship with the Southern Trust and with Bernadette and Rory. So I'm delighted that they've joined us this afternoon to share their experiences and the experiences of young people, and perhaps in Rory's case, not so young anymore, and gives us a chance to hear their lived experiences. So thank you very much, and I'll hand over to Bernadette and Rory. I'm not sure who's starting off, but I'll leave that to you. Thank you.
Good afternoon. We'll just give Bernadette a second there. Good afternoon, everyone. I would like to introduce Dr. Bernadette Salisbury, who is a consultant clinical psychologist for the Southern Area Acquired Brain Injury team. I first met Bernadette about 7 years ago, just before I started university. Bernadette has helped me understand the difficulties I have faced after an acquired brain injury. She was the first person I felt I could really open up to, and without her continued help and support, I would not have achieved what I have to date.
Thanks, Rory. Welcome, everybody. Apologies for the initial technical difficulties there. Rory won't be surprised, but this is Rory. Rory Keenan is a person I've come to know very well. I have a lot of respect for. Rory's been involved with our community brain injury team at different points since his injury, since the past 10 years. When he first had his injury, Rory was supported by ourselves in the Southern Trust, as well as medical review from Dr. Maguire, consultant in rehab medicine. Rory returned to school and he got on with things, but he's referred back to the team a number of years later for support in regard to anxiety, and that's where I first met him. And it speaks to really what a lot of the speakers today have been talking about, that it's about getting the right support at the right time and that you need different things at different times. Psychological therapy can be tough. It's difficult to sit in a room with someone and talk about the things that make you feel scared or vulnerable, or the things that make you laugh. And Rory's always been willing to engage fully in therapy, even when it's been challenging. He's been motivated to make real change in his life. So we have a saying in psychology: how many psychologists does it take to change a light bulb? One, but the light bulb has to want to change. So Rory wanted to change and he wanted to learn about himself and move forward. So Rory's medical report from 2009 stated that he felt unwell while playing football, and then he woke up the following morning with a frontal headache, nausea and vomiting. Continued to deteriorate over the next few days, developing confusion. So thankfully, Rory received very prompt medical attention and treatment in hospital, which is really vital to reduce the long-term consequences of encephalitis. He was diagnosed quickly and started treatment. So Rory sustained an acquired brain injury when he was 16 years old. Encephalitis is an inflammation of the brain. It's caused either by an infection invading the brain or through the immune system attacking the brain in error. Anyone of any age can get encephalitis. There's up to about 6,000 cases in the UK each year, and potentially, though, because it can go undiagnosed, potentially hundreds of thousands worldwide.
When I look back now, I believe I was very young and did not really understand what had really happened to me. Being so young when I had encephalitis, all I wanted to do really was go back to school and be where my friends were and just be the same as them. I can't really remember much about going back to school, but my mum always says to me how difficult I found it. On that first day, I didn't really know the school layout and got really confused. I found it difficult to really ask for help, and did not really want to talk about my feelings when I was that age. This caused me to push my friends away really and lose interest in the things I really enjoyed.
Oh, sorry, Rory, I'm really messing up this presentation. So Rory was referred to Ebert after his diagnosis in 2009. So our team is made up of speech and language therapy, physiotherapy, occupational therapy, social work and clinical psychology, and we're very much supported by our admin staff. We work closely with our consultant in rehab medicine for the Southern Trust, Dr. Maguire, as well as all of our other colleagues in the Trust in physical and sensory impairment and mental health. And we've really strong links to local volunteer organisations, charities and third sector organisations. So Rory's goal in 2011, he worked with occupational therapy and speech and language therapy with the goal to really about getting him settled back into school. So Rory's really had a very MDT approach and intervention with our team. We're going to focus most on the psychology side of things. So in February 2014, he worked with psychology to increase his confidence in getting it together and be able to follow things through. On September 2016, unfortunately, he had his first seizure. So for lots of people with acquired brain injury, the threat or possibility of a seizure is a real concern. In some circumstances, the likelihood of having a seizure is slightly increased after acquired brain injury. So sometimes this can mean taking extra medication, which can have an impact on physical functioning, which can cause us to be more tired, just in case. So unfortunately, Rory went on to have further seizures in January and July in 2017. And the goals at that time in relation to his psychological intervention was fatigue management, driving and anxiety around driving, and social isolation. And I guess the value of our community brain injury teams throughout the region is that we're able to respond to the changing picture of ABI across the lifespan. As many of those with brain injury know, you need different supports at different times. During his time that we worked together, different life events happened for Rory, some successes. He achieved a first in his degree from University of Ulster, and other very sad events, such as a long-term sickness and the loss of his father. Really what we want to focus on today is thinking about recovery from brain injury, and it's a very individual process. If you know one person with a brain injury, you know one person with a brain injury. The vast majority of brain injuries get better over time, and when you're working, lots of people, young people with brain injury, we're trying to help them understand that, this hopefully won't mean a huge difference in your life, that you can get on and achieve things that you would have achieved anyway. But we need to reflect on the things that do impact on recovery and recovery over time. Brain injury can definitely affect our sense of self, our confidence, and our mental health over time. So there may not be an organic reason that we're of a loss of confidence, but because we've suffered a brain injury, it can make us feel a little bit shaky or lacking in confidence or anxious.
The final point, really, when you're younger, all you really want is for everything to go back straight away, but it's not always like that. That I can especially relate to that. When I was in my teens, all I wanted was everything to go back straight away, as I said previously, and be just like my friends. But this wasn't always possible due to some of the difficulties I faced. For example, I was tired a lot, which meant you couldn't do the same things that your friends could. This really caused me to lose my temper and get frustrated easily when I couldn't do things or do things wrong, or especially forget words when I was communicating. This made me angry, anxious, and seen me isolate myself a lot from my family and friends. At stages, I thought I would never get over these difficulties, which always, when you look back now, was hard to take. Some of the difficulties I faced probably throughout the start and into my working career was making phone calls, driving, and meetings. It was always the small things I found the most challenging for me. For instance, when I had to make calls in work at the very start of when I was in placement, I always found this difficult. I always thought in my head that I would mess up, forget words, not being understood by others, and people would end up laughing at me. This seen me try to resist making calls and sometimes even making calls on my own, which didn't really help my job. And this took me so long to overcome, as Bernadette would tell you. I had so much difficulty learning how to build up confidence in myself over the years, but eventually I did get there, and at where I am now, I could make calls no problem. It was the same with driving. I got my license when I was 20, when I was allowed to, because all my friends really had got it and they pushed me to get it as well. But then when I eventually got my license, I started to get these anxieties that something bad would happen, so I put off driving for so long. As I reflect back now, I just needed to really build confidence in myself and to get over these fears. Bernadette and her team did everything for me to really help me get over these. And over time, I was able to reduce these anxieties and learn how to be confident in myself, which was the most important thing. Now I don't even think about where I am now. I don't even think about making calls or being involved in meetings, because it's that confidence I built in myself over time, which makes me so happy when I look back through my journey.
And just to say, guys, now Rory makes, how many calls would you say in a day? Rory works as a content surveyor. He's actually in the south of France at the moment on a job, and he's living a life.
I actually try not to make the calls. It's people ringing me the issue now.
Oh, you have people for that, Rory, do you?
No, it's the people ringing me that annoy me.
So working with a psychologist, maybe just thinking about what that means and what that looks like. So when we think about the research that is available to us using psychotherapeutic approaches after brain injury, there is a lot of research, although it's still growing, it's still in its infancy. Most of the research on therapy after brain injury is dominated by studies on what we call CBT, cognitive behavioral therapy, and quite a few of the previous presentations have mentioned CBT and CBT approaches. And there's a lot of positive results from CBT as a standalone intervention. But CBT only goes so far. And a lot of times studies are only noticing partial reductions in symptoms of anxiety and depression, and it's not going to be suitable for all patients or difficulties. So Rory and I started with a CBT approach when we thought about answering the phone and his driving, talking with friends and public speaking. And then we would have done a lot of mindfulness as well.
Yeah, so really when we started to complete the CBT, it helped me understand my problems, but I always found that it didn't really let me overcome all the difficulties. This, when I look now, this could have been because I was young and didn't really understand what exactly was wrong with me. Working with you, Bernadette, really got me prepared for university, which was always such an important step, as you know, to help me. Getting to university was a great feeling and really allowed me to see that I've achieved something in my life. As I look back now, university helped me learn, it's so important to help me learn to interact with other people and help build confidence in myself. I always remember that first meeting I had with one of the lecturers and how scared I was and afraid to talk to him. And then as I look back now, I remember on results day, he even said how far I'd come and how proud I should be of everything. The work with CPD allowed me to set goals, but I always find it difficult to work on a number of them at the same time. For instance, throughout university, I put a lot of effort into doing the best. And when I kind of got the first class and got the result, it was nearly like I was doing it for other people and didn't really appreciate it myself as I looked. But now, kind of when I was getting prepared for this, it's when I reflect now, it was the relationships I built in university were probably the most important thing out of everything. For instance, when the job I'm in currently is due to one of the lecturers giving me a recommendation to my boss, which I look now and was so important probably in everything.
And thinking about within mental health approaches, there's a shift in direction to what we call third wave therapies. So moving away from targeting intervention for psychological events like thoughts towards aiming to change the function of these events and the person's relationship with their psychological and contextual experiences. So further examples of sort of new wave or third wave therapies would be mindfulness-based cognitive therapy, acceptance and commitments therapy, and compassion-focused therapy. So there's been a lot of really exciting research on compassion-focused therapy and brain injury in the last few years, typically mostly with Fiona Ashworth, Paul Gilbert, and Fergus Gracie. And as it happened, I had an opportunity to attend quite a lot of training for CFT. So Rory and I decided that this would be a useful model when we started to work together again. People with acquired brain injuries frequently experience psychological difficulties such as anxiety and depression, and these may be underpinned and maintained by high levels of self-criticism and shame alongside an inability to self-soothe. So compassionate focused therapy was developed to address shame and self-criticism and to foster the ability to self-soothe.
When we started the compassion focused therapy, I had just started taking seizures in 2016, and to be honest, at that stage I had felt I had hit rock bottom and found it so difficult. I felt that I had really lost my independence because I had started driving again, and almost for a year I felt this way. I continued working throughout 2016, but then I had lost interest in everything outside of work, and I felt I really needed help at this stage. When Bernadette introduced me to compassion focused therapy, I felt I really could understand the difficulties I was facing. I started completing actually a lot of mindfulness after the seizures, and I found I could really implement CFT into the mindfulness, which was really helpful.
Yeah, and I guess just to mention as well, that impact on what we do every day. So most people here will know if you have a seizure, that means sort of automatically you can't drive for up, well, 6 months in some cases, but 12 months for most people. So there's that level of independence that immediately gets taken away. And that's really, really difficult for people to cope with. Many people with brain injury might blame themselves for their difficulties and are often very self-critical, thinking if only I'd done this instead, or it's my fault it happened, or if I hadn't gotten into that car, or if I'd walked a different way, or very negative self-statements like I'm stupid, or I can't remember, I'm always saying the same thing. So compassion-focused therapy was developed to treat shame, self-loathing and self-attack or self-criticism. It's transdiagnostic, and it's useful for working with diverse conditions like low mood, anxiety, or trauma. It draws upon the science of human nature, evolution, and attachment, our relationship with ourselves and our relationship with others. So compassion-focused therapy hypothesizes that key underlying processes are present across mental health difficulties, and that these are central to maintaining psychological difficulties like low mood or anxiety. We use lots of neurophysiological approaches to help regulate or control our emotions and to manage our emotional well-being in daily life. So thinking about compassion and what compassion is defined as the sensitivity to suffering and the accompanying motivation to make it better or to prevent further suffering. So compassion is the ability to see distress and to do something about it, the desire to do something about it. So everyone will experience pain in our lives, but suffering is a particularly human ability. So suffering is associated with the way that we experience our own minds. And the goal of CFT, or compassion-focused therapy, is to alleviate suffering by developing our own caregiving or compassionate systems. So the caregiving system has the qualities of non-judgment, strength, warmth, empathy, wisdom, kindness, and moral courage. And treatment using CFT involves learning about human nature, learning skills to develop a caregiving system, practicing activating the caregiving system and using it in our life. Thinking about the key messages from CFT, we might think about the things that have happened to you in your life aren't your fault, but it is your responsibility to alleviate your own suffering now. And compassion is really about choosing to be the best version of you that you can be. So thinking about compassion and the three aspects of compassion. The skills of compassion involve learning to direct our attention in a compassionate and a helpful way, learning to think and reason in a compassionate and helpful way, and learning to behave in a rational and compassionate way. So if we think about these three aspects, there's my compassion towards myself, my compassion towards others, and allowing others to show compassion towards me. So thinking about ourselves, maybe just right now in this room, how good are we at really being kind to ourselves, noticing what we need and being good to ourselves, being kind to ourselves. Perhaps most of us are probably better at being compassionate to others, helping others out, showing others compassion and care. And the third aspect is a really tricky one for people, allowing others to show love and care for us. So when was the last time we asked for help, said what we need, sought out love and care from others, or really allowed someone to take care of ourselves? So the CFT, or compassion-focused therapy, proposes that human beings have three systems for managing their emotional states. And each system has different motivations, focus, our attention, thoughts, emotions, and body feelings. And each system is associated with the different parts of the brain and with different neurochemistry. I suppose that's particularly why I think compassion-focused therapy works really well with working with brain injury, because it links so well with parts of the brain. And we have a saying in CFT, this idea of our tricky brains might try and make us think something or feel something that maybe isn't true. And everyone with a brain injury will understand, the idea of a tricky brain. So thinking about these three systems, then we have our drive system. And that's really us focused on a goal, incentives, excitement, we're driven, we're vital, we're working towards something. Our threat system, this is the red circle, focused on really, those difficult emotions like anger, disgust, anxiety, feeling under threat, feeling under pressure, feeling worried, feeling scared, feeling vulnerable. And then this green circle, our caregiving system. These are, when we're in the green circle, we're feeling soothed, regulated, safe, content, connected. So Rory and I spent a good bit of time talking about these circles and this model of understanding the self. And Rory was able to talk about how he felt he'd been in threat or drive mode for quite some time, but perhaps his soothe system wasn't really as developed as it could have been. So we're going to think about a few examples. Now I'm going to use myself as an example. So this is me before the conference, about 20 minutes ago. Quite a big red circle, kind of worried if I got all the information. How do I share my screen? Is anybody going to knock on my door? Is my phone going to ring? Do I know what I'm going to do? But a big blue circle as well, because I'm focused on kind of getting things done, and a really small green one. This is me now. I've done this quite a lot. I'm not too nervous, but I've got a bit of a red circle, but I'm focused on getting through this conversation, this presentation. So quite a big blue circle and a small green one. I'm still not that relaxed. And hopefully this will be me after the conference, where I'll be really relaxed. It'll all be over. I'll be having a cup of tea. I'll probably have a bit of a red circle because I'll be thinking, oh, did everybody like it? How did it go? How's Rory doing? But quite a small blue circle because, I don't have that many more things to do today. I'll be, finishing up and heading home. So that's kind of an example of how these circles work. And you might think yourselves right now, if you had to draw your own three circles right now, what would it look like? So Rory and I are going to give an example of a therapeutic conversation. So this is a tool that we use ourselves in therapy just to help us think about these three circles and how our different systems might impact on our behavior. So this is called the lion and zebra example. So you may have heard this already, in which case bear with us, but hopefully this will be a fun experiment for most people. Okay, so Rory, you're just going to pretend that we're in session then. So we're just going to look at this zebra in the field, Zoe zebra, and she's a mammal, just like us. So Rory, what do you think Zoe might be thinking or feeling?
How great it is to be out in the fresh air, lovely green fields with her friends.
Mm-hmm. Yeah, perfect. Yeah, she's in the green and blue circles there, isn't she? She's getting some food, focused on that drive, being near her family. She's feeling safe, so she's mostly in the green, feeling safe, feeling secure. But in the distance, a lion begins to stalk. So Zoe hasn't seen the lion yet. So she's still where she was, but this is happening in the background. And oh no, the lion attacks. So what is Zoe zebra thinking and feeling now?
Panic, stress, I'm going to die.
Yeah. Okay, exactly. So I think in session where we might have used a few more choice words, but we'll keep it on clean for this session. So yeah, so Zoe is, her breathing has increased, her adrenaline has increased, all those neurotransmitters are coursing through her system, just like it would for us when we're in threat. So she's screaming, she's really in a red circle now. But the good news is Zoe escapes. The lion doesn't have the energy to keep going with the attack. It slinks away, it's exhausted, and Zoe goes back to the grazing. Rory, what do you think she's thinking and feeling now?
Glad that's over. What has happened? Oh no, it could happen again.
Yeah, that's a really good guess, but actually Zoe is just going back to thinking about food and family. She's going back to her original said. So all those neurochemicals, all those adrenaline, everything is settling down. Her breathing is returning to normal. So she's just going back to thinking food and family because the threat is over. So the big difference between us, what humans do and what other mammals do, is our tricky brains, isn't it? We have this amazing frontal lobe, which means that we can imagine things and remember difficult experiences that have happened to us. So while for humans, we might keep replaying the lion attacking or dangerous things happening or difficult things happening for us, for other mammals, they'll just go back to their previous just family and feeling safe, worried about food, focusing on what's right in front of them, the here and now. But it's not typically how humans react. So using CFT, we're trying to really learn about ourselves and how we use all these different therapeutic techniques. And what we're going to share now is Rory's own CFT formulation that he did himself. And just to say before Rory starts, if you can, guys, I don't know if you are, but maybe make sure if you can that you're seeing the full screen rather than side by side, and to minimize the presentation view so that you can see the full screen if possible.
Yes, so this was the model I kind of prepared for myself. I really felt this model, I could really understand it and what my goals were, what I want to achieve, but also the difficulties I faced achieving them. So it was easy to pick up anytime, just quickly look and see where you are, what circle you're in. The drive for me is more or less the same as it's been since I prepared this back a number of years ago, and I always still want to achieve them, and probably it's about myself, my family and my friends is the most important. The soothing was always a challenge for me and to implement into aspects of my life. Being compassionate, I always found challenging, but over the years, I've probably been able to improve this a lot. The threat was always large as well, and it was difficult to make smaller because I was always worried about the worst case scenario happening with everything I did. But over the last few years, really, I've been able to reduce my threat down and make my soothing and drive the largest of the three circles. This has allowed me to work on all my goals at the same time, and feel happy with myself. Working with the model really made it easier for me to understand the different aspects of the brain and how you can change them yourself. I've completed a lot of mindfulness probably over the last years when I was implementing this, and I found it easy to implement compassion-focused therapy into it. I always finish my mindfulness sessions by asking what circle I'm in at that stage. And still to this day, I'm using this model, Bernadette kind of laugh, but I find it so easy, and it's so easy to pick up when you're having a difficult day, but also when you're having a happy day and making memories. And probably the most important aspects of compassion I always remember is ask for help, accept help, and give help.
Okay, so during our work together, Rory and I, we focused on using CFT to create a wellbeing plan for Rory, just to look after his mental health every day. So physical health and mental health are just the same. They need to be looked after every day for all of us. And most of the people in this room are very aware of their physical health, maybe watching what they eat and maybe taking some exercise. And mental health is just the same. We need to do things every day to look after ourselves. So Rory's going to talk a wee bit about what he does to maintain his emotional well-being.
Yeah, so as I've got older, it's easier for me to understand the importance of self-help for everyone, but especially people who have acquired brain injuries. I'm pretty good at some things and then poor at others. I'm good at understanding when I'm tired and I need to take time to myself. I'm pretty good at this in the evenings after work when I'm very tired. I kind of know that that's my time and that's all I'll be doing. I understand how important it is to have a positive mind. This has probably been brilliant over COVID for me, being away from family and friends at times and not being able to meet up. I've been able to take time to myself and understand what's important. Exercise, as Bernadette said, exercise and diet is so important, especially when you're taking tablets and you have some issues. I'm actually really good at this at the minute, understanding the importance of mental health and diet and getting the most out of my day through this. Also, what I'm very, very good at is probably technology, which helped when I done ICT in school. I use this a lot, probably at the very start, to implement technology into cognitive strategies. I still do this today, using a lot of apps and spell checking, especially in work. Also, I use Excel a lot to kind of control what I'm doing in life and understand. I always find that that was so important, probably the IT side, when a lot of people didn't understand. I could kind of use things, and probably even in work, a lot of the ones say how well I am at doing things that help probably make my work life easier. But probably the biggest self-care I looked throughout the years and all this is probably in 2017, when I decided to take a year off work after a number of seizures. I knew it probably was one of the worst times, and taking that year off probably was the best thing for my career and myself. It helped improve my mental health and also build confidence that I never had before, which was probably, look back now, it was so important to me.
So I guess it sounds so simple, doesn't it? Just be kind to yourself. But this really is difficult. Making compassion a part of your life is tricky. It's a continual process. It takes a lot of work, and it takes a lot of commitment and reflection.
Probably, yeah, compassion focused therapy. When I look back now, kind of, it was so easy. Well, it was easier than other kind of things we had used Bernadette before, but I found it really easy to implement into my life and understand what compassion meant. At the start, it probably was difficult, but where I am now, it really helped so much. I feel that I can talk more about my anxieties and can see the challenges I have with them. One of the big things I always kind of still worry about is taking another seizure. But over the years, I've been able to reduce this through compassion in myself and understand that even if I take another seizure, what will really change in my life? Not a lot. I'll still be able to do my job. I'll still be able to achieve my goals. And when I kind of have this control over myself and confident in myself, I know that I'm in control of my life. And that's probably the most important thing.
So I see Joe there, so we've got our few minutes warning there. Sorry, Joe, we're going to take another minute.
That's grand.
You've given us the platform. We're not saying goodbye. Just from a therapist point of view, thinking about using CFT in the 3 circles, Rory alluded there, he did take a year off, and that was a really interesting discussion that we had as myself as a therapist and Rory as the client. So it was really important for me to listen to Rory's wise mind and that decision. Some of the therapists listening today will appreciate that sometimes when your client gets back to work, that's a sign of real success. And Rory noticed for me that maybe I was asking about getting back to work. Is it right time to take time off? I was concerned, I was worried, I was in my red circle about that. And Rory was able to soothe me, to reassure me, to notice for me that I was getting anxious, getting worried about this. And it was actually a very healthy thing for him to do, a very brave thing for him to do. And he'd been in drive for years and years at that point, throughout school and university and working, and taking a step back was a really, really wise and compassionate decision for him to make. And because he was able to do that, he actually ended up, as he described, in a really fantastic role as well that works well for him. A couple more, if that's okay, guys.
It's kind of, when I reflect back now, probably over the last 12 years, I have been lucky, really lucky, to have a lot of support throughout at different stages. Family and friends, the acquired brain injury team, Dr. McGuire, my local Gaelic club, charities, my work colleagues at the minute is brilliant as well for me. But I do want to say Bernadette was such an important help to me throughout the whole process, and I don't think I'd be here today without that help. And that's probably the most important. Where I am now, I'm so lucky, work's going great and other things I want to achieve, but I'm really looking forward to using my experiences to help other young people that have acquired brain injuries. And I'm looking forward to getting involved in the Brain Injury Matters program, the mentoring program that's going to start up in the next few months. So I'm really looking forward to that and hope my experiences can help some other people. And finally, it's probably as I've got older, I kind of can reflect a lot more, and probably the main support, and everyone can relate to this, has been my mum and dad throughout it all. As I reflect back over the last 12 years, I had a lot of ups and downs, but I'm so lucky that I can truly say my mum and dad did everything for me to really help me get here, and without them I wouldn't be speaking here today. They were the rocks really that pushed me on in my recovery at each stage, and for that there I'll ever be so grateful. I reflect a lot since my dad has passed away, and I always come back to thinking how proud he would be of me and what all I've achieved and what I can still achieve. I know this motivates me every day really to push on. Also, what can I say about my mum? We're now closer actually, and we chat more than ever. Even though she still treats me like the little child, it's what just frustrating at times. I know it's out of the love she has for me. It is now I really understand the importance of their support was to me, and for that I'll be so grateful. And I really look forward to the next stage of my journey. Thank you all for listening.
Rory and Bernadette, thank you very much. That was fantastic, very powerful, and I really enjoyed it. So thank you. And just to advise everybody, because of I think the nature of that presentation, I thought it was really important to let it continue for a wee while. We'll be moving back our break at 3 o'clock, but in the time we have, I was going to ask you, first of all, Rory, thank you for sharing your experiences, very personal, and doing it so freely and so honestly, and congratulate you on all your successes, and particularly the fact that I think I picked you up right, you're currently in the south of France.
Yeah, yeah.
Well done. Yep. Okay.
That's
right. So congratulations on that. Two maybe quick questions to you, if I may. You're now at a slightly more mature stage, or in terms of age. I mean, if you were speaking to your younger self, what would you say to yourself all those years ago now? And also, what would you also say to the professionals that you're working with? And then a question for Bernadette. And Bernadette, I thought the outline in terms of compassion theory was really fascinating. And I wondered again, is that something you feel we could see more of in working with young people with ABI? Mindful, as you said, everyone's an individual. So two different questions to each of you. So Rory, I'll maybe go to yourself, if I may, first.
The big thing, and I actually do reflect a lot probably over the last two years really, since I have got a wee bit older, the biggest thing for me was I really pushed myself to get on to university and do what every other person was doing, but I ended up taking two years longer anyway. And it's probably when I look back now, I go, everyone's got a journey. You don't need to do what everyone else is doing. You'll still get there at the same stage. And I ended up doing that. And it's kind of, till I was in that university environment with other people that were a lot older, you understood that age is only a small thing in really it. So especially for a brain injury, I thought that was important.
Thank you, Rory. Bernadette.
Yeah, I think it's very individual, Joe, that you say, you know, I'm a big fan of compassion focused therapy. I think it works really well. It's an easy model for everyone to kind of understand and get on board with. It's goal focused, and it helps people think about, you know, where they are in their life and reflecting on why they might do the things that they do and why they might think the way or act the way they do. So it really is a lovely model, but it's brain injury and recovery from brain injury is very individual. And it depends on your support system around you and what resources that you have, everything that all the other speakers have alluded to. It's just finding the right fit for the right person at the right time.
Lovely, thank you. And again, just picking up Rory's point at the end where he's volunteered, if that's the right term, Rory, to be one of our mentors. And
coerced.
Coerced. Well, I was using the term broadly, but loosely rather. But no, it's tremendous. And I think the fact that you and others are giving that back, and as we know, young people will listen to you much more than they would any of us, whether professionals or clinicians. So it's a fantastic gift you're giving other people. So I want to thank you for that, and thank you to Bernadette for putting the presentation together. You really were an example of a partnership in action, even if Bernadette maybe wasn't as good as you in the technology, Rory, but you know.
I'm so sorry.
But really good. But thank you both. It's been an absolute pleasure, and I look forward to hopefully you can stay on for this afternoon session as well. So thank you.
Thank you.
It's a pleasure. So what we're going to do now, given the time, is to take a break until 3:15, and then we'll be back for the parents panel. And again, very keen that people would join us this afternoon. So we'll take a short break and be back at 3:15 sharp. Thank you. Good afternoon, everyone, and welcome back to our final session in today's conference. It's great to see so many of you are still with us today. I know for some it's been a long day, but hopefully people have found it really interesting and enjoyable. Just to reiterate the importance of questions and comments, we'd really welcome those through the Q&A. Secondly, if people want to promote the conference, albeit we're coming to the end, through our hashtags, and also to remind you about our evaluation, which will be with you shortly. One of the key themes of today has been the importance of listening to and understanding the voice and position of families and siblings as part of that. And I'm delighted to come to the end of our day to have an opportunity to listen to the lived experience of families. And this afternoon, I'm delighted to be joined by a panel of distinguished parents. I told them I would describe them in that way. Also joined by Professor Siobhan O'Neil, who's interim mental health champion. The parents have volunteered to be with us this afternoon following a wee bit of coercion or gentle arm twisting by Bridget and the team. So I'm really pleased that they're here with us this afternoon. So I'm just going to, excuse me. I'm just going to start this afternoon by welcoming all the panel. I see Gemma, Sarah, Jacqueline, Elizabeth, and Siobhan. Siobhan's, I don't know if you can hear Siobhan. I see you're, oh, there you are. Lovely to meet you. How are you doing? So I just to get the afternoon started off, I was just going to ask our parents this afternoon just to introduce themselves, and I'll maybe pass over to Gemma to start off. Thank you, Gemma.
Thanks, Joe. Hi, my name's Gemma. I live in Derry, and I'm mum to Lola, who is 17, Mary's 16, and Jacob's 3. My daughter Lola was 16 when she suffered a traumatic brain injury in March last year. She was on her own, walking her horse on a country back road at my parents' house in Donegal. Lola's lost all memory around that time, so we don't know exactly what happened, but have pieced together from her phone messages and injuries that her horse probably spooked and knocked her sideways. She woke up alone on the road and was luckily found some time later wandering the farm. She was injured and bruised with a sore head, really confused and unable to retain any information. I took her straight to A&E and Lola spent 5 nights in the general ward. Lola's CT scan that night in ED was reported as no abnormalities detected, and her MRI scan reported to us on the ward later was with DAIs. She was discharged with the advice to avoid risk for a few weeks and then able to resume normal activity, which most importantly for Lola meant she could ride her horse again. We were lucky to get the advice to self-refer to Brain Injury Matters, as I was so worried about what was happening to her. She was suffering really badly with symptoms, and they listened, supported and offered Lola coping strategies at the time when we had nothing else. 3 months post-discharge and a long conversation with her GP prompted a review from a neuroconsultant, and he reviewed her scans and accurately reported her CT showed a mastoid fracture extending into the temporal bone with some air, and that her MRI had been changed to report frontal and temporal contusional hemorrhages due to a contracoup injury, which we didn't know. The neurologist made many referrals, and Lola promptly received her first neuro rehab assessment 4 months post-injury. I've raised the delay in diagnosis and treatment with our trust, and it's been addressed in an SAI report and complaint. I find it hard to accept it's over a year and Lola is still in her recovery journey, receiving rehab in comparison to how she was discharged. It was so far from the truth and reality of what lay ahead for Lola, her pain, symptoms, physical and mental challenges. Never did I realise this was long-term and life-changing for Lola. But she's doing really, really well. And although still not able to ride her horse, she's well on the way thanks to the support she is getting from her neuro-OT and an OT in hippotherapy. Lola has been patient, strong and quietly determined throughout. She keeps me strong and reminds me how lucky we are to have her here and how amazingly well she is considering. So for that we're very grateful.
Lovely. Gemma, thank you very much. And I'll pass over to Elizabeth.
Two girls, Faith and Lydia. At the age of 11, my daughter was diagnosed with a rare and complex deep midbrain brain tumour. She's now 15 years old. Initial medical prognosis and management decisions were very bleak, and were very difficult for us as a family to accept. However, following an incidental second opinion by Great Ormond Street in London, we were given a very different opinion in terms of our treatment options, which would also then change her prognosis. After a very difficult number of months, my daughter had major brain surgery in Great Ormond Street Hospital. As predicted by her neurosurgeon, she did, as a result of this surgery, have further brain injury to the affected area, but thankfully the surgery went much better than planned. Her brain injury has resulted in a serious lifelong medical condition. She is dependent on a very heavy regime of medication, both for development and for survival, and she can become very ill very quickly, leading to hospital admissions. She, on a daily basis, has low energy levels and high levels of fatigue throughout the day. She receives periodic reviews as the tumour is known to be recurrent in nature. Associated with the nature of her brain injury, she also has mental health issues. Prior to her brain tumour, my daughter had already received a diagnosis of dyspraxia, autism and mental health issues. That's the thing with brain injury, it hits normal families who are already dealing with normal issues, and in our case, these issues had already felt like they had reached a crisis point. But brain injury is indiscriminate. Brain Injury Matters came on board after my daughter's surgery, and by this stage there were many issues that we needed help with as a family. Unfazed by the complexity and the range of these needs, they journeyed through these with us, helping us to face them, accept them, and where possible, overcome them.
Okay, Elizabeth, thank you very much. I'll maybe pass over to Jacqueline then for a short introduction. Thank you, Jacqueline. Thanks, Elizabeth.
Hello, my name's Jacqueline. I live in Derry with my husband Seamus, and we have 5 children, and they range in age from 15 to 24. Our second youngest child has an acquired brain injury due to a massive stroke when she was only 14 years old. Before Roisin had her stroke, she was a very happy-go-lucky, loving her busy life and loving life to the full young girl. And our beautiful daughter had always been a very high achieving pupil at a grammar school, getting A's and A stars in all areas of the curriculum. She played guitar and clarinet and had already achieved grade 3 in the clarinet. Roisin was highly confident with grades and singing and drama, and she had performed in many dramas and shows, and she was really passionate about singing, being a member of a few award-winning choirs, and she sang solo in many big events. She also played Gaelic football with our local club, and she even travelled with her team to represent Derry in the All-Ireland Failure in 2016. Roisin never missed anything. She had 100% attendance at everything. In January 2019, Roisin had a stroke, which left her having to spend 3 months in hospital, where she had to learn to eat, she had to learn to talk, even sit up, then stand up, and eventually get on her feet. It also left her with massive damage on her brain, which means she has an acquired brain injury. Roisin left hospital using a wheelchair, and we had to get a hospital bed in the downstairs of the house, and I had to take her to hospital every second day to shower. It was a complete nightmare. 2 years on, Roisin has life-changing disabilities. The stroke has caused Roisin to have a weakness on her right side, so she walks with a distinct limp. She has foot drop, so she has to wear a splint, which she absolutely hates because it looks so obvious. Her right arm and hand are non-functional, so basically she has to manage with the use of one arm. The brain injury has also affected her academic ability. She had to repeat a full year at school. She has a full-time classroom assistant. She has a statement. She's doing the minimum amount of GCSEs, and she needs a lot of help with those. And she cannot take part in PE. She will never play contact sports again, and so she had to give up her Gaelic football. She probably will never play her clarinet or guitar again. And the saddest and most difficult issue that Roisin has at the present time is that she has no friends. And in school, a group of girls talk to her, but she has no contact with girls her age outside of school. And it's absolutely heartbreaking.
Okay, Jacqueline, thank you for that. And I'll just pass over to Sarah, if I may, Sarah, for an introduction. Thank you.
Thanks, Joe. Good afternoon, everyone. My name is Sarah. I am the mother of a 7-year-old boy called Matthew, who has been living with an acquired brain injury all his life. Around the time of Matthew's birth, he suffered a stroke and now has the condition of hemiplegic cerebral palsy. This affects all the limbs on the right side of Matthew's body. We live in a rural part of Northern Ireland with my husband, Matthew, and our other 5-year-old son. Coming to terms with a life-changing condition in our firstborn child has been extremely difficult and has given us many different and ongoing challenges over the years. As a parent, you appreciate so much the child in front of you, but you always also sometimes reflect on the child that could have been. While any child's future is unknown, the prospects for a child living with an acquired brain injury are not on a par with others living without an acquired brain injury. And even life's smallest daily tasks can be a mammoth challenge, not only for the individual affected, but for the family unit as a whole. Thankfully, in January of 2020, we began working with Brain Injury Matters and have seen a lasting improvement on the quality of life for our family. While we still have daily struggles, we now have understanding, appreciation, and information on what life may be like from our child's perspective. So we feel better equipped as a family moving forward harmoniously.
Thanks very much, Sarah, and thank you all for your introductions. I'm just going to ask Siobhan just to introduce herself a wee bit in her role, if I may, briefly, Siobhan, before we move back to look at some of the in-depth issues and challenges facing our parents. Thank you, Siobhan.
Absolutely. My name is Siobhan O'Neil. I'm a professor of mental health sciences at Ulster University, and at the minute I'm the interim mental health champion for Northern Ireland. I was asked to do that role in August, and it came at the New Decade, part of the New Decade New Approach deal, which promised an action plan for mental health, and in that action plan was the idea of a mental health champion. And the reason why we progressed it so quickly, or why the Minister progressed it so quickly, was that they wanted to improve mental health services very, very urgently. We realised there was a great need, and I have been speaking many times publicly about this issue and about the need in Northern Ireland. So we had our draft strategy that was published in December last year, and we're now working on the final version of the strategy, which would see a transformation of mental health services across the region. I'm also working with the Department for Education on their skills framework, mental health and skills framework, and other departments. It's across departmental remit, so I advise all government departments where there's a link to mental health, and there is in most of them, as you can imagine, specific projects in justice and infrastructure around trauma-informed practice and suicide prevention in public places. And it is an honour to be here. I feel just so humbled to listen to the testimonies of parents, parents like me. I have a wee 4-year-old, so I totally just, it's heartbreaking, the stories that I'm hearing, and I want to know how we can improve services and support for families and for individuals with acquired brain injury.
Thanks very much, Siobhan, and thank you all for your introductions, because I'm conscious, you know, there's a pressure of time in these things, but I'm also very much aware these are your stories and your experiences, so I want to respect that and give people an opportunity. I was going to ask, listening to the introduction, maybe ask you to say a bit more, each of you, in terms of sort of the issues and challenges you have faced over that period, and I'm mindful, you know, there's lots of things you might want to share with us, but I was going to ask you maybe to pick up on 1 or 2 of the key issues and challenges you faced, and just to share that with us in the time we have. Sarah, I'll maybe go to you first then, in terms of, for you, what have been the key issues and challenges?
Yeah, okay. So the first issue, I suppose, that I would like to raise is viewing the holistic impact of the acquired brain injury on the child. So following our son's diagnosis, we felt that very quickly we became absorbed into a routine of physical therapies and appointment, focusing on Matthew's physical development. And while this was very reassuring to us as parents, we have also identified in hindsight, and having worked with Brain Injury Matters, is that we had actually received very little information in terms of the brain injury itself and how it may affect our child's life outside of that sort of physical sphere. Yes, we had a diagnosis and a condition named on paper, but we did not fully understand the implications of this in terms of our son's development, sort of socially, emotionally, and behaviourally. There have been many times where, as a family, we have been left feeling at breaking point, trying to overcome sort of emotional challenges that we were unequipped to deal with. The physical impact of an ABI is only one part of a disability, and I think sometimes it's the easier to put actions and treatments in place for. Having worked with Brain Injury Matters, we have been able to identify better our child's emotional needs and how to manage and actively put in place strategies to assist him. I believe it is of pinnacle importance that the psychological, social and emotional needs of the child are elevated to the same status as any physical needs and are assessed and addressed on a regular basis. Information regarding the potential impacts of the brain injury on the daily life of a child should be shared and learned from, so families can understand and prepare for potential future challenges that they may face in a supported manner. With that said, I feel that psychology services and clinics should be more readily available to children with brain injuries to assist with their own understanding and acceptance of their condition, and how to move forward from this, embracing their capabilities and their strengths so that they are not being left to feel inadequate. This is certainly a hurdle that we have been trying to vault as a family for the past few years and seem to be making progress sometimes in the form of a 1 step forward, 2 steps back scenario. But what I can say for sure is that having the information and knowledge in relation to the potential impact of the ABI has given me as a parent a lot of confidence. I can now present reassuring encouragement in a confident manner, and this is allowing me to role model to Matthew a better way to deal with the challenges that he may face and lead by a positive example.
Sarah, sorry, my apologies, I cut across you. Go ahead.
That's okay. I was just going to go into the second issue, Joe, if that's okay.
Please, yes, please do.
Yeah.
Thank you.
Perfect. So the second issue that I would like to raise is really school and the education system and what sort of is currently in place in Northern Ireland. So fortunately for ourselves, Matthew's statement of special education needs was in place for when he began primary school. The process itself of getting the statement in place in our own area took over 2.5 years, and this is perhaps something that can be expedited. In terms of what is in place in Northern Ireland, I do feel that the EHCP provision that is in place in England goes an awful lot further and provides more of a holistic care package approach to assisting children with actually succeeding at school, rather than the simple provision of a statement of needs that we have currently in place in Northern Ireland. Having full access to the curriculum is the child's right, so I believe that all measures should be in place to allow for this to happen and to give the child a fair chance to succeed. While our child's statement was already in place and an assistant specifically employed to help him while at school, his experience, in particular for the first year of primary school, but for the remaining 3 years, has been largely negative. He is in a class of 20 pupils, and while he has many good days at school, there are many days where, due to how he presents with his condition, showing fatigue, anxiety, frustration, leads to non-compliance with general classroom etiquette, and has in the past led to a situation where he has been ultimately and literally isolated from his peers. Clearly, his teachers and assistants who have been employed to support him specifically have felt unable to read and understand the situation, have been unable to identify Matthew's feelings and how to meet his needs in a positive and supportive manner. I feel that if some information or training had been available to the school at the start of his education journey in P1, on brain injuries in children, this could have been an entirely different experience for Matthew and for us as a family. Of course, all brain injuries are different and complex and unique to the individual, but having access and advice on hand for school communities would have been extremely beneficial and allowed for the school to put strategies in place to assist Matthew at a much earlier stage. I want to note also that the Education Authority has a current consultation focusing on the provision of specialist education in both special needs schools and mainstream schools with additional specialist units. Matthew attends a mainstream school which does not have a separate specialist unit, and at this current point in time, he hasn't been identified as needing to attend a specialist unit. But I am unsure if the scope or the outcomes from the current EA consultation will bring any sort of change for children like Matthew in mainstream schools. It would be my hope, certainly, that any areas of best practice, areas for change that are identified in the current consultation can be put in place in mainstream schools. so that all children with additional needs, like those with ABIs, who do not attend a specialist unit or a specialist school, are not left to fall between the cracks.
Sarah, thanks very much. And I'll just pass over to Jacqueline. Jacqueline, for me then, just from your perspective, the sort of issues and challenges you have faced as a family. Sorry, Jacqueline, you're on mute. There you are, thank you.
There we go. Well, firstly, I'm going to talk about a misdiagnosis that Roisin had. Roisin was diagnosed with inflammatory bowel disease on the 3rd of January 2019, and she started on a course of steroids. And shortly after that, she spent a long weekend in hospital in Belfast and was discharged around about 3 o'clock on the Monday, the 14th of January. And as soon as we got home, which was around 5 o'clock, Roisin lost her ability to speak. She couldn't get any of her words out. So we phoned the GP, and the GP advised us to go straight to A&E. Now, personally, I thought at the time that Roisin was having an allergic reaction to the steroids. Roisin had said that she had a fuzzy feeling on her forehead, a funny feeling on her tongue, and whilst coming up the steps to the hospital, she had to stop to get her breath. So when we arrived at A&E, the receptionist told us to take a seat. And after an hour or so, a doctor checked Roisin out. And I told the doctor the symptoms that Roisin had displayed, you know, the fuzzy feeling in her head and the funny feeling in her tongue. The doctor did a few neurological tests, and his main conclusion, and I'm quoting the doctor, she's only 14 years old and it's highly unlikely that she'd have a stroke. 5 days later, Roisin had a massive stroke. And my blood boils when I think about this, because on that night, Roisin actually had a TIA, and a TIA should be treated as a medical emergency. What if a blood test had been done or a CT scan had been carried out that evening? Maybe Roisin would have been prevented from having the massive stroke that has now changed her life forever. Now, the other area that I want to talk about is the gap in services for 14 to 18-year-olds, especially limited services west of the Ban. Because Roisin was in hospital in Belfast, where she had brilliant care and attention. Her rehabilitation started straight away, and there were OTs, physios, speech therapists, psychologists, even dietitians, social workers, play therapists, neuro disability consultant, orthopedics, opticians. She even needed a dermatologist, one straight away the next day. There was music therapists, teachers from the hospital school, and she even had a reflexologist. So each day in hospital was very intense and very busy. There was even support from groups such as Helping Hand, which paid for Roisin to go out of hospital for a few hours. For example, she went on a truck to the museum. And Roisin made terrific progress in a short time after leaving hospital, even being able to walk through the doors of the hospital using a quad stick, but then she was straight back into her wheelchair. Roisin got out of hospital after 2 months of intensive rehabilitation in Belfast. And when we returned home to Derry, there were a period of 4, maybe 5 weeks when there was no rehabilitation at all. I look back at this with deep regret, because the first 6 months after a stroke is the period when most recovery takes place. And the reason for that was because there just was no place for rehab for a young person. Now, thankfully, a consultant in the adult services agreed to take Roisin for rehab. And I have to point out that the therapy she received with the adult services was brilliant. There was OT, physio, psychology, and speech and language. I don't felt that at all. But a separate entrance had to be created for Roisin to avail of the therapist and the centre to avoid her coming through the adults. And I often wonder, though, if Roisin had been sent to a specific rehabilitation centre, specifically for young people, probably with the stroke, would she have recovered more in her arm and her hand and her walking? I felt that there was an overload of services and therapists in Belfast compared to what we've been offered here in Derry.
Thanks very much, Jacqueline, and we'll pick that up later on during the conversations around the services being spread evenly or appropriately across the north. And
Yeah.
Gemma, may I pass over to you then, just to share your issues and challenges, and one or two of them you alluded to in your introduction. Thank you.
Yeah, so in Lola's case, probably there was two key issues, the delay in diagnosis and treatment, and the lack of post-discharge advice and follow-up. So I think they're linked in that we left hospital with an inaccurate diagnosis and no follow-up treatment because of that. I would like to think and believe that if Lola's CT scan was reported accurately at the time, she wouldn't have waited 4 precious months for rehab. As Jacqueline mentioned, the greatest progress with rehab is made within the first 6 months post-brain injury. Lola's discharge letter was the only advice that we did leave hospital with. It was in a quick summary quote: the family were advised to contact Child Brain Injury Trust. Lola was advised to take no risk for the next few weeks and attend ED if there was a relapse. I remember walking off that ward so worried about what lay ahead for Lola. I knew there was something not right. But we were constantly reassured throughout our 5 days in hospital, and I know that's part of the medical staff's role. You want to believe and respect that. We were reassured her CT scan was clear. We were reassured everything happening to her was normal for concussion and head injury. In ED, Lola was so clearly unwell to me, but I struggled for the staff to see what I saw. On her triage notes, it actually question marked if she had anxiety. In triage, when I questioned about the clear blood-tinged fluid coming from Lola's nose, I was again reassured, and I quote, "It is only serious if it is coming out of her ears." We were reassured on the ward that her MRI reported as just DAIs. That's what the doctor said to us. Now, we didn't know what DAIs are, and he did, and I quote, described it that it was like shaken baby syndrome. So there's small scatters of bruises on her brain. Whilst an inpatient, Lola constantly said her hearing was muffled, like she was underwater. And again, we were reassured that was probably wax dislodged from the trauma. An ENT doctor advised her to get some drops on the way home. This sensation took months and months to subside for Lola. And we did later learn that it was actually a common symptom of a mastoid temporal bone fracture that she had suffered. We were reassured concussion and head injury would take a few weeks for her debilitating headaches to subside and her memory would improve. It didn't really. We were reassured the weakness in her arm and hand is probably just from the bruising and injuries that she'd suffered, or maybe from her IV where that was. She was later diagnosed with impaired dexterity. It was a theme that ran throughout Lola's experience in hospital. Everything was okay, it was just concussion and try not to worry. And obviously I don't expect medical staff to recall every conversation or detail. They have a very hard job and are under a lot of pressure. ED was so busy that night, and I know the ward Lola was on was awaiting the impending pressures of COVID. But I won't forget the conversations. You cling to every detail as a parent. So I don't forget as I watched her fall apart that night and keep falling apart for days, weeks and months to come until she started to receive rehab. Lola presented to ED that evening not with anxiety from a fall, not just concussion, but after waking up in a road, hurt and alone, with no memory, no comprehension of what was happening. She presented with a fractured skull and contusional hemorrhages. It's on the scans that were taken at the time. She had such obvious brain injury symptoms, and yet she was discharged 5 days later with no medical follow-up, no assessments, no rehab and no advice. I have a great feeling of guilt that I didn't speak up louder, beg and push for more help. I feel I let her down by not trusting my gut instinct. I was her voice and I didn't speak loud enough, but Brain Injury Matters have helped me deal with those feelings, and I was so lucky to talk those through because I was struggling and I needed to be strong for Lola. 1 month after Lola's discharge, our Trust Community Brain Injury team did ring us and advised something that we hadn't heard before, and that they said strictly no physical risk for 6 months, which kind of maybe might have been a big saviour for Lola, because they had reviewed her MRI and said her injury was quite serious and it would warrant that advice. We were shocked because, you know, we were told just 3 weeks, no risk. And I was shocked because it was the first time someone had referred to her brain injury as serious. This call also briefly highlighted, as Jacqueline touched on, the gap in service for young people with an ABI. our Trust Community Brain Injury team advised that because Lola was 16, they couldn't offer her treatment as they're an 18+ service, but then there was no paediatric service either for her. So they advised us to self-refer to Brain Injury Matters. 3 months post-discharge, Lola's ongoing visual concerns led to a long and empathetic call with her GP, who made an urgent referral to the neurologist, and Lola finally received the accurate diagnosis and referrals and rehab. When Lola received her OT assessment 4 months post-discharge, it identified a long list of brain injury symptoms and challenges, which she finally began rehab for. So despite the initial challenges, on a plus note, Lola is now receiving amazing treatment from her neuro rehab OT, physiotherapy, and some much needed psychology, although this is very limited and delayed because of service pressures. She also has an amazing therapist in equine gaits and hippotherapy, which is ideal for Lola. Lola has met other kids there and now volunteers with her. Lola used to compete in show jumping Ireland, and with this amazing therapist will hopefully achieve her goal to ride her horse again someday. Lola has a care plan in place at school and support from Senko, and she's now getting support from the Cedar Foundation with adult life skills and hopefully going on to further education, which is amazingly positive, and she's doing brilliant. And for all that, we are so very grateful. I also know we are very lucky. Lola's journey, although difficult, certainly isn't an exception, and it certainly isn't the hardest. It is humbling to hear the other parents' stories today and the strength that they have shown. Also, on a positive note, there are recommendations that have come out of Lola's SAI. It was hard for me to make a complaint to our trust. I work for them and I have great respect for the staff, as I know only too well how hard they work and the pressures that they are under. But I knew I had to. Something went wrong and we can learn from that. And if it makes one ABI patient's journey better and one family less stressed, then it'll be worth it.
Okay, thanks very much, Gemma. And I do appreciate how difficult it is to share such personal experiences. So thank you for that. Elizabeth, I'm going to pass over to you now, maybe just for your perspective of the issues and challenges you and your family have faced, and then I'll go to Siobhan to maybe get some comments or reflections on those. Thank you, Elizabeth.
Yeah, okay, well, mine overlaps quite a bit with most of what has been said already. I know we share a lot in common as parents, so hopefully it won't be too repetitive. For us, the main challenge has been acceptance really of what has happened and obtaining mental health support, both for my daughter and for us as a family. Acceptance is a crucial part of healing and moving forward, but with the exception of Brain Injury Matters, there was no help offered for this. In about 10 minutes, we were given a life-changing diagnosis, and then we walked out the door. I learned quickly to toughen up, suppress, and just get on. No one seemed to see the need to offer us a space to talk and process. And after all, we were now dealing with the important situation, medical situation, and navigating this new medical physical world that we had just been thrown into. This was complicated for us further by the fact that most, if not all, of our medical services were now and continue to be provided outside of Northern Ireland. However, I underestimated how important it was to give myself that time and opportunity to both acknowledge and feel the range of emotions that existed as a result of our journey. Some of these have already been mentioned by the other parents. So I had extreme feelings of guilt if I had picked up on symptoms earlier, guilt if I had pushed for a second opinion earlier, grief for what had been lost or what had been changed. And to complicate our journey of acceptance further was the undealt feelings of frustration that the medical opinion that was given to us was incorrect, and that was only a result of a pure incidental situation. Did specialists outside of Northern Ireland clap eyes on my daughter's MRIs and then become involved? And this raises a lot of what ifs, and this has definitely made it more difficult for me. Accessing mental health support for my daughter post-surgery has been a real challenge, and probably despite the fact she's now living with a very serious, life-threatening, life-limiting medical condition, I would still, similar to what Sarah said, highlight this above and beyond any physical or medical situation that we face on a daily basis. It has been such a challenge. We have gone from pillar to post, and this is despite being known previous to her brain injury to both autism and mental health services, given the diagnoses that she had from other conditions. And now we were having to face mental health issues that were associated specifically with her tumour. I think to illustrate this pillar to post would be to just give an actual example of one experience that we have had. So just prior to surgery, my daughter was attending autism services, specifically in relation to mental health issues. A number of months post-surgery, I contacted them again as mental health was continuing to be a big problem, and now we had the addition of the mental health issues associated with her tumour. When I called, I was told that she'd been discharged. When I queried as to the reason why she was discharged, I was told it was because the psychologist had left their post. So I asked, well, can someone else not see her? Can someone else not take her on? And then I was told that the post had been unfilled, and they hoped at some stage in the future they would employ a mental health worker to join the team. But in order for my daughter to even have a chance to see them, she would need to go to the GP and be referred back into a service that we had been attending for years. And they had a file as big as I don't know what on her, but yet we had this effort to go to get her back into the system. So I asked at that stage, could she be seen by CAMHS instead? Again, because she had previously attended there before her diagnosis of autism, and we had been attending there for about a year. But I was advised that because she now had the autism diagnosis, she needed to get her mental health support within autism services. So I accepted that. I went to my GP, I got her referred in, and following a very lengthy wait, we were eventually seen. And then only after 2 appointments, we were told that due to her presentation and the addition of her medical needs, she did indeed need to go to CAMHS. So we had to go and join another waiting list and get another referral made. And we waited some more. Unfortunately for my daughter, we did not get to wait as long as expected, as we had an emergency mental health crisis, which resulted in an emergency appointment. Accessing a mental health service is the first challenge. There's also the issue of infrequency and lack of actual therapeutic appointments, as well as the poor coordination between professionals and agencies. My daughter's experience in school, due to her mental health, can at times only be described as survival. This is despite having a statement of educational needs and despite being in a very supportive school with an SNA. I was very interested to learn and hear earlier on in the conference more detail of the role of the educational psychology. That is not only an assessment-based service. My daughter's needs impact both on her and the resources of the school significantly, and I would welcome such support to be offered and become a real experience for us. Mental health needs to be taken as seriously as physical health, and I say this as a parent who experiences both on a daily basis.
Elizabeth, thank you very much, and thank you all for sharing those issues. It's clearly, as we said earlier on during the day, everybody's injury is different, everybody's experience is different, but clearly there are also overlaps. And I wondered, Siobhan, just listening to those reflections, the issue around, you know, people have been moved from pillar to post, the lack of services, the delays in accessing services. It seems to be a world away from how we sometimes earlier on during the day perhaps describe the services and the close interworking between health, education, the voluntary sector, whereas with parents here clearly feeling that that's not the case. And I just wonder, from your maybe broader experience of mental health, how true is that from your broader experiences? And also, is that sense of people not appreciating the need to invest properly and adequately in mental health very much a message you're hearing a lot?
Yeah, so thanks firstly to the parents and mothers for sharing their experiences. Really devastating stories, actually. So the experience with mental health services varies considerably. I mean, if you have a straightforward mental health condition that's common, that you can go to your GP and you have the right GP, many people can receive treatments, effective treatments at an early stage. You know, it does work for a lot of people, and we rarely hear those stories, but all too often, you know, this is the kind of thing, people can't access services. So in terms of the journeys that you're talking about here, for me, it just seems to be one trauma on top of another. So you have something awful that happens, you know, to cause a brain injury in your child, the worst thing imaginable, a huge trauma to the child and to the whole family. And on top of that, there's the trauma of trying to navigate services. And it seems to start in so many cases with a lack of, you know, even getting a diagnosis. Even that part of it isn't working right, even understanding what's happening and the misinformation, and then knowing that for all of the brain injuries that we're talking about, rehabilitation and early intervention and those first few months are so important. So when you're looking online and you've got access to all of this information, and then you realise what hadn't happened, and that's your child, and it's the trauma for the child, but not alone that, for the whole family. We know these things are all dynamic and interact, you know, they interact with one another. So when the family's under pressure like that, the child's mental health is going to be affected too, in addition to everything that's already happened to that child. So it would seem to me that that mental health services are needed right from the start, but they need to be integrated with the physical health services here and the neurological services, the services around the brain injury, because the two kind of go together in that sense as well. So so all of that stuff at the start about problems getting diagnosis, and I realise this is a whole complex area, but it just doesn't seem good enough, you know. And I hope that the investigations that are happening are full and transparent, and that, you know, there is a deep understanding of what went wrong to cause those delays, because that just compounds everything else. So even moving on to the rehabilitation services that are there, and the patchiness, the lack of equity across Northern Ireland, and these issues have been raised particularly in the Royal College of Psychiatrists response to the strategy. I was just pulling it up there, and the Northern Ireland British Psychological Society. Both those professional groups have highlighted acquired brain injury, young people with acquired brain injury as a group whose needs aren't being met well, and have a whole list of actions, and I've then mapped them on to my response to the strategy. So this is in the strategy responses, all of the areas that you've identified, but particularly rehabilitation services. And then that need for regional equity is so vital for this group, because we talk about children and young people, and that's an important group. This group are even more important because of what's happened to them, and the need to capitalise neuroplasticity, you know, of those childhood and teenage years. So these are priority actions as far as I'm concerned in the strategy, but, you know, the actions within the strategy are going to be they're going to be rank ordered, and it's a year-on-year actions. So I don't know when we'll be able to deliver on those, and some of them require buildings and training of staff. So that pediatric psychology service, for example, that the NIBPS have recommended, you know, the educational psychologists will have told you this as well. We need more training in both those areas, more people trained in Northern Ireland, and it takes quite a few years to get to that point. So we need to be putting in the training places now. So workforce planning is relevant to all of this too. So those are my thoughts around the provision of services. It's really not good enough, and it's absolutely heartbreaking to hear about, you know, a group of young people and families that aren't getting the treatments and the support. And you're right about therapeutic appointments. So there's appointments around the condition, but there's you know, there's unlikely to be those therapeutic appointments unless you get access to a psychologist or a psychiatrist for a specific type of therapy. And people are so disappointed when they realise that that's not what the appointments are about. You know, when you go to an appointment, that's not what you're getting. It's not an opportunity to talk. It's just, you know, it falls far short of what people expect from services for these conditions and from mental health services.
Thanks, Siobhan. And again, I suppose it's emphasising the complexity of it, that parents, as a parent, we're looking for guidance, we're looking for information and support, and sometimes what we're faced with is a barrage of clinical information and conversations, which oftentimes are, certainly as a layperson, way above my head, and you're just left as a parent totally confused. One of the things we're keen to look at today, and again, without being trite or trying to lessen the real challenges facing all the families here today and others who we work with, are solutions. I mean, we're hoping today to look and give out messages from this conference as to what would make things better. And the mental health strategy, I think, should be a key plank of the response, not only in terms of ABI, but across a range of issues. And as you said, Siobhan, it's around priorities and resources. And I was going to ask our parent panel this afternoon, maybe just to reflect a bit on what they feel would make a difference. What are their priorities? And again, I know everybody would have a long shopping list of things that need to be invested in, but I'm just going to maybe put the challenge to you individually to say, well, if there's one or two things you feel would make a big difference, what would that be, and what would the message from today's conference be from your particular perspective? Jacqueline, I'll maybe come to you first, and you mentioned rehab, so maybe around that area.
I suppose if I had a magic wand, the thing I would like is to have had like intensive rehab for Roisin within those 6 months, you know, that we didn't have that gap where there was 4 or 5 weeks where she just had nothing, you know. So intensive rehab, and I suppose a specialist unit for young people in our local area.
Lovely, thank you very much. Gemma, what about you? What would your wish be? Sorry, Gemma, you're on mute. Sorry.
There we go. Sorry. I think for us probably it would be one key person who is accessible. We were very lucky to begin treatment with an advanced practitioner occupational therapist in neuro rehabilitation. And that title is well earned, she deserves it. Lola received, Lola's treatment has been excellent since we've been there. And I feel it is because she's become one key person who's advocated Lola's needs and chased up all the referrals and the appointments. And despite COVID, she met Lola face to face within guidelines. The value of having a key person to navigate between the adult and paediatric services, figuring out who could and should provide treatment. She was a key person, much appreciated, who cared enough to always be accessible, always come back with help and advice and any time. She lifted the weight off my shoulders and understood and cared as much as I did. She was constantly assessing and treating Lola and linking with the other departments and also her school to share support and understand was in place there. So my wish would be that the Northern Irish Health Service would recognise and invest in the value of someone like this and how much it would improve the care pathway for ABI children and young people. And also just to touch briefly on a point that I made earlier on the role that Brain Injury Matters played in supporting and counselling me through the emotional trauma of what happened, Lola, and the acceptance of it, and helping me be strong again for whenever Lola needed me most. So because one wish is never enough, I would also hope for the Northern Irish Health Service would invest in mental health support for ABI patients and families, recognising the importance of those counselling services provided by the CBIT and Brain Injury Matters. This was a big positive actually that came out of Lola's SAI report that our trust has recommended, and I quote, counselling support for ABI patient and carers post-discharge from the acute hospital setting with a clear pathway for future care and onward referrals to community brain injury teams.
Okay, Gemma, I didn't think we'd get away with one wish for Gemma, so thank you for putting a second one in. If I may then, no problem, thank you. Elizabeth, may I turn to you then in terms of your wish or priorities?
My wish would be for increased mental health and emotional support for families immediately after diagnosis and also the months following, as well as long-term plan to support the young person. I think at all of those different levels, it's very much required. You had mentioned earlier about the varying impact that families have when they first learn of their child's brain injury, and it's been relived with some of the parents today. Those images, smells, the words spoken, they will be forever ingrained in our minds, and they most definitely do positively and negatively shape how we go on to care, not just for that child, but for our family as a whole. So to have that support early on, I think is absolutely crucial, and I will be forever grateful for Brain Injury Matters for picking us up really from the ground when they came on board and helping us work through. They were the only people in our journey, despite making lots of professionals, that took time to help us to process and move on. I just think mental health services in general, we've talked about this, they need to be better resourced in terms of staff, they need to be restructured, they need to offer timely, ongoing quality support. I feel that it's been close to, I can only call it begging for mental health support for my daughter. 3 years post-surgery, I've yet to receive an appointment in the post that I have not begged for, that I've not asked for, that hasn't come as a result of an emergency or some level of persuasion on my behalf. And I just think that's totally unacceptable. You know, these children have survived something that as adults we have never experienced. They are very vulnerable children in terms of their mental health. And I believe if we were properly invested in resources and new structures, the long-term mental health impact for these children will be reduced. Just even thinking back to the example I shared of ringing and being told there wasn't a staff member there to provide mental health support in a service where there should be mental health support. That would be an outcry if I rang the Royal to book an MRI appointment to be told the consultant radiologist was unavailable to read my child's MRI results. I mean, it just wouldn't happen. Or you go to the review, there's no nurse there, sorry, we're short of nurses, nobody can take your bloods. So I don't see how it's okay then for us as families to be told these things when we call for mental health support. So that would be my wish, that we can be confident that all our young people with or without brain injury can easily access and receive the mental health support that they need and I believe deserve.
Thank you very much, Elizabeth. Sarah, may I pass to you then for your thoughts on your own particular priorities you would like to see?
Yeah, no problem, Joe. My wish would be intervention for the child from an early age to allow the child to understand and accept the event that has happened to them, the condition and the acquired brain injury that they are now living with, and to give them time to sort of digest that information and to allow them to accept that for themselves. We're seeing now as a family with Matthew, and he's only 7 years old, that he has already experienced, and particularly in the last year, experiencing some very low mental health points. And I would openly admit that I am concerned about this for the future. And I suppose it reiterates what the other parents have said here today, that, you know, mental health really impacts their ability, you know, in every aspect of life, their ability to learn, their ability to socialize, you know, their ability to carry out daily tasks. So my wish would be that services existed. You know, we're in Fermanagh, so we have very little services locally unless, you know, we can travel to get, you know, to access services. And even at that, with whatever services are available, you know, we've been in the position where we've been waiting 2 years to get an appointment. So just if services were available to us that could address those needs throughout Northern Ireland, you know, without long waiting lists, and that would provide that ongoing support, not just a tick box exercise where you come in for an appointment, you're seen as being consulted with, and that's you discharged. Ongoing support and care to both the child and the family. I suppose a wraparound care would be the best way to put it.
Thanks very much, Sarah. And Siobhan, just as you were listening to those comments, I suppose one of the other issues, I suppose, is that need for early intervention for young people, and that sense of the demands been placed on the health service. And again, as interim mental health champion, I presume it's, you know, it's a key role in your job to say, well, what can we do about that? So without putting it on the spot, I just wondered what your sense is of a response and how that might be addressed.
Yeah, early intervention is always crucial, and particularly for this group of very vulnerable young people, it should be an absolute priority. It's a very urgent thing. It should be up there along with, you know, care in a crisis. It should be automatic, and the support for the whole family should be there. The whole movement around trauma-informed practice is relevant to this conversation as well, because we're talking about a group who've had a trauma, young people who've had a trauma. So the idea there is that you would put in support to identify at the earliest possible stage the signs of any mental health problems, so that you can start to address them, and that you give everybody coping strategies. And I think one thing that was really emphasised there was the importance of the continuity of care and having that key person. So whilst there be different interventions from different parts of the service, that one person to provide the support so that you can go to, and that person would help you navigate. And that's where the wraparound care comes in. It's through having that person. And I think some of the the suggestions that I made in terms of the strategy around peer advocacy models are really relevant to this as well. So I hear so much about the benefits of the charity, the charities in your own organisation in providing support, and it can be very, very useful to hear from other parents and to connect with other parents here. So what we'd like to see though is a structure of peer advocacy and peer support that means that the advocates have their career structure, that they have their support, that they have training, so that they're not volunteers, they're actually doing this, and they're trained to do it. And I think that would be a very, very powerful system of support for families and young people, and would also help connect young people who've had brain injury to others with similar conditions, with similar difficulties, so that they could foster hope and have that sense of support. I mean, Jacqueline's story, Roisin having no friends, that completely broke my heart, and that's something that schools, under a trauma-informed ethos, they should be looking at that, because they know relationships are so important, and schools should know that behaviour in the classroom is indicative of psychological pain and distress, and that behaviour is a way of communicating feelings. So if we got the trauma-informed message around about mental health services and across society, that's what we want of the strategy, so that everybody recognises the importance of relationships and support and what behaviour communicates. So that would go a long way to help children and young people as they through their rehabilitation too. So those are some of my ideas that are outside of the provision of services. I think the support that's offered generally, and I think that counselling after this sort of traumatic event and ongoing support is absolutely essential, and would prevent problems in the long run. It would be money well spent, because it would pay dividends later on in terms of the needs that these young people will have as they they go through life.
Thanks, Siobhan. I'm just very mindful again. We're starting to look at peer support for young people in the Southern Trust, and have a pilot program there. I've just listened to stories there and people's own reflections, and I wondered if I may ask, and I haven't advised you will be asking this question, but I wondered in meeting with parents who are just about to start down this road, and it's obviously a very difficult road, and every experience is different. Is there one piece of advice you would give to them, or one piece of advice you would give to the professionals or clinicians that are working with the families and children in that position? So again, I'll just maybe start with Elizabeth. What would you say to another parent who's just about to enter this world?
I would say don't be afraid to ask for other opinions. First and foremost, if we're going right back to the very start, don't accept initially what you're told. I quickly learned Northern Ireland is a very small place, and so I suppose if we're going right back to the very start, I would say follow your instinct. You know your child best. You have a right to ask for second opinions and for more information. And then I suppose also what I would say is just to prepare yourself for the fact that you are going to be that your child's advocate for everything. You very quickly, in the absence of having that key worker, that wraparound that all sounds perfect and ideal, in the absence of that, my advice would be to prepare yourself mentally, emotionally. You need to be ready and strong, because the journey is not easy. So just, I suppose, alongside that, just taking time, which I didn't do, which then made it more difficult for me to be able to support my family properly, was to take that time for yourself to get that mental health support for you, to be strong for that journey for your child. Because all of our children here, these issues are not going to go away next week. You are facing, a lifelong issues here, and I think it's very, very hard to accept. So I think all of that would be very important, just ongoing support for yourself to be able to face the journey, which realistically you need to get up every morning and fight that battle, and you need to be strong and able for it. Sorry, you really put me on the spot there, Joe. Well, so I'm not quite sure if I answered the question.
No, that's thank you very much. That's perfect. Sarah, what about you? I mean, what would you say to a parent?
I would reiterate, I think, what Elizabeth had said there, Joe. definitely with myself the whole way through our family's journey. I suppose the shock and the fear and that you receive as a parent from getting a diagnosis, and that sometimes you're kind of afraid to ask questions or that. So one of my pointers, I suppose, would be don't be afraid to make your voice heard. Don't be afraid to speak up, you know, ask a second and a third question and a fourth and a fifth. Don't be afraid to maybe challenge, you know, some of the information that you're hearing and ask for a step further in terms of information. Again, like Elizabeth has said, you know, I certainly feel like there's hardly a day goes by where I'm not mentally preparing myself for some sort of follow-up phone call. I feel like I am forever chasing appointments, forever. You know, I feel like if I'm not on top of what Matthew is due in terms of checkups, you know, routine appointments, things that should be coming down the line, you know, you're constantly phoning and chasing up and trying to figure out, you know, timelines and things like that, you know. So while it's easy to maybe feel guilty about maybe things you could have asked previously or things you should have done, maybe put your energy into sort of being organized and just being the voice that your child needs you to be.
Lovely. Thank you very much, Sarah. Gemma, could I pass to you then, maybe just to your take on that question?
I think probably will be repeated again from Sarah and Elizabeth. Trust your gut. Don't be afraid to speak up, question and challenge. Just, you know, we put our kids first, and sometimes we feel like we might be the fussing mother maybe and don't want to challenge any medical opinion. But I think from these stories, the mum's gut instinct has been right, and you just need to be strong and stick up for your kid, and also look after yourself. It's I mean, it's stressful on the parents. The mums have a hard job to do, so the stronger the mums are, that's the better for the kids, you know. So just look after yourself as well.
Lovely, thanks very much. And Jacqueline, finally to yourself.
Again, I'm going to repeat what they all said. Just trust your gut feeling and speak up. If you think something's not right, say it and demand another answer. It does become a full-time job. The whole caring for this child with a new injury or whatever, it just takes over your life. And I found that I personally devoted all my time to rushing, and the other children didn't get a look in. They nearly weren't cared for anymore. They were caring for themselves. So it became a full-time job. And one last wee thing I would like to say, we're 4 people that have ability to speak up. But a concern that I would have is there could be a parent that wouldn't have the ability to speak up or wouldn't recognise, and that's something that is another area, I know, but you know, we are voices for our children, but there are other children maybe wouldn't have a parent would be a good voice for them.
Yeah, thanks very much, Jacqueline. And I think that's a really good point. And I think the 4 of you are fantastic advocates, obviously speaking from lived experience and the experience you've had and for your families as well. But there may be others who, that's why I asked the question, would look to you and to say, like, how do you cope here? You know, how do you manage this situation? Siobhan, just maybe a comment from yourself at the end, anything you want to reflect on? I know we've, you know, maybe raised a lot of issues this afternoon here and a lot of very challenging issues for people, but something you'd like to add just as a closing comment from yourself? So you're on mute, Siobhan, sorry.
Yeah, I was going to say, yeah, I think it's so important that we listen to families, we listen to parents, we listen to people who've been affected and hear what it's like from their perspective. Because when we're designing services, you know, the way they're designed, it's not, we rarely go through the journey from the service user's perspective, you know. And when I hear about, I know, like, being a parent is a full-time job anyway, and that you have to dedicate your life and your days to navigating services, it should not be like that. You know, we need to do better, and we need to listen more and design services alongside people who have used the services so that we can really get this right. I think that's the only way forward, and I'm so grateful for people like the parents today who are sharing their experiences, and you know, hope that the strategy will bring some positive changes. But we need to continue to campaign for this group and to make sure that mental health services are prioritised in Northern Ireland in the middle of everything else that's needed right now, but particularly for our children, you know, so that we can give them the best lives possible. So thanks again for having me here today, and I've learned a lot through it, and thanks for sharing your experiences.
Thank you, Siobhan, and we were delighted you were able to join us, because we're very mindful of not only your experience but your role, and we felt it was very important to hear the voices firsthand and can reflect that in your work. And I genuinely want to thank also Sarah, Jacqueline, Gemma and Elizabeth for your very powerful and very moving sharing of your experiences and your family experiences. I've had the pleasure to meet you a couple of times, and it's been an honour to hear you share those experiences, and I'm mindful of the fact we could spend the whole day, and maybe should spend the whole day giving you a chance to have a platform, and as people who are very articulate and speak from the heart. So it's been an absolute pleasure. I think it's rounded up our conference, and I think it's hopefully given everyone tremendous food for thought, and you couldn't help but be moved and informed and hopefully challenged by what we've heard this afternoon. So if this was a normal conference I would be asking people to give you a round of applause, but failing that, I would like to give you a round of applause, say thank you. It's been fantastic, and thank you for giving up your time and sharing your experiences, and hopefully see you all very soon. Thank you very much, and I will move to the closing comments if I may, but thank you to the panel. It's been a pleasure. Thank you very much. Thank you. So thank you everyone. As we get to this part of the conference, as you'll be aware from the beginning of the day, this is a partnership endeavour between ourselves and the Belfast Trust, and therefore it's my pleasure at this time of the day to invite Dr. Ewan McCrudden to offer his own take on the day and offer some closing comments before I finish off, and we'll endeavour to have you away as quickly as we can. So Ewan, over to you. Thank you.
Joe, thank you very much, and to all the parents who spoke just now, thank you. I think Siobhan mentioned this as being a humbling experience, and I would just like to echo that sentiment. I suppose as I've sat here and listened, I'm reflecting back to some of the work that we did quite some time ago, again with another group of parents, the Talking Heads group. One of the things that we asked them to do, and Siobhan, it goes back to your point about designing services around what families and parents and children need, as opposed to what we as service providers want to do. One of the things that I always come back to is to the parents who sat and talked to us about their experiences and their recollections of coming through hospital, the ICU stage, the acute medical management stage, the discharge to community, and a lot of the things that were mentioned by the parents just now about that negotiation and how they were asked to find their way through services without a route map, without any way to orientate it. The thing that always sticks with me about that is that when those parents had finished their discussions and we then looked at our evaluations of the training that we had provided, virtually every service provider will always reference the fact that hearing the perspective of the parents and hearing what the care that we provided was like is one of the most influential things in terms of them thinking about how to change things, how to improve things. It's unfortunate that it sounds like there are still areas for development. And that's clear from the cases and the children and the young people that were being discussed there, that there is still room for improvement. But I suppose I would also go back to the prior discussions with Bernadette and with Rory as well, where obviously the potential is there for us to actually have meaningful, helpful, useful, good outcomes as well. I think one of the things that people have made reference to, and I've been kind of watching the comments coming in the Q&A function as well, this issue of the availability of a kind of a post-acute service. It's one of the things that Dr. Meakin mentioned earlier on, and Minister Swan mentioned earlier on as well. And it certainly sounds like from the discussion that we had today that was one of the things that we do need to be kind of mindful of. I would just like to point out one thing as well. I think there was one reference that was made to the numbers of children who are actually sustaining these injuries every year. We don't actually have completely reliable data on that, but I know that Ruth and Maria mentioned a number of about 1,300 children per year. I just wanted to clarify that while that is a rough approximation of what we think it would be, the vast majority of those children will actually have mild or less severe injuries that will necessarily result in some of the types of long-term difficulties that we've heard people talking about in great detail here. So it is something to bear in mind in terms of the number and the extent that we're talking about. But as I said, I think hearing parents and hearing people like Rory talk about what their experience has been like is the kind of thing that we need to have to get us thinking about how we continue to develop these services. Things have moved and changed since the review of acquired brain injury services that was published back in 2011, about 10 years ago now. But that doesn't mean that the job is finished just yet. And I think from what we have heard today, there is more than enough evidence of where we can be improving things across the region. Joe, you're on mute.
About Sarah Meakin's earlier slide about Christopher Robin been halfway down the stairs, I think clearly there has been great progress made in service delivery and many miles to go. So there's a lot to be done. I suppose from me, just listening to the conversations today throughout the day, I suppose the take on it I have is, and you highlighted it yourself, Ewan, is the complexity of the issue we're dealing with in terms of ABI. Everyone's injury is different, everybody's recovery path is different, and therefore it does require that multidisciplinary approach we've heard today, and also the importance of working in partnership. And I think yourself, Ewan, have highlighted the partnership between yourselves, the voluntary sector, the education sector, and I think that really sets a fantastic framework for moving the services forward in delivery. Again, like yourself, hearing the experience of parents throughout the day, and Rory again just reinforces the point we need to have families and their experiences at the heart of everything we do, and that applies to all service providers, including ourselves. We shouldn't presume because we like what we're doing and we think it's good that we simply sit back. And I think the experience of COVID has taught us that we can change our services and change things as much as we can. I suppose finally, listening to all the presenters today, one of the key things is that need for an integrated regional services for children and young people across Northern Ireland, and making sure that that service does come out of the review of neurological services and is properly resourced and in a sense gives everyone their place. So I think we have had a lot of learning from today's conferences. We're very keen that we will capture this as much as we can in a conference summary and use that in partnership with yourselves, Ewan, and the other trusts, and getting those messages out of there. So I just, maybe if I may, just at the end of the conference, just offer a few quick words of thanks. I'm very mindful that a conference of this nature is a result of a partnership, and I just wanted firstly to thank all the participants, everyone who's joined us today from the start of the day right through to this afternoon. We have had a really good turnout and engagement, so thank you to everyone who's done that. I wanted to thank the Minister for giving his time today, and we'll be mindful of all the pressures on the Minister, to Gordon Goff, our Chair, and Sarah Meakin on behalf of the Trust for her words of thanks. For all the presenters, and Ewan started the day off, and Chris and all the others, I mean, for really, I think, detailed, comprehensive, and in some cases, very challenging presentations. And I think they've been of really high quality. So thanks to all the presenters. To the parents who I've mentioned before, and for taking the time. Not only did they attend today, but they also attended several sessions with us in preparation for today. So they've given up a lot of their time for the conference today. I also want to thank everyone from the Brain Injury Matters team who pulled this conference together. Those in the team who presented, Meg and Catherine and Susie and Bridget, but also all those who worked behind the scenes today. Trasa Rice, Francis McConville and Fiona Hendren, who put all the work in that's very much appreciated but not often seen. And that also applies to our team in ND Events, who have done all the backroom work and made sure the conference has gone from a technical point of view seamlessly, and that's been down to them. And finally, I'd want to thank Ewan for his work in devising and supporting us in the conference from day one and getting support from the Belfast Trust. And also a special word of thanks to the architect and the driving force in the whole conference, who is Bridget Smith, who's our head of Children and Youth Service. Bridget has pushed and prodded and guided this conference over the past almost a year and a half, and stuck at it and has worked very hard to put all the presenters together. And as anyone who's been involved in a conference will know, that's not an easy task. So I wanted to finally say thank you to Bridget for all her work. Thanks to everyone today, and I would appreciate if everyone, as soon as they have their evaluation, can fill that in. If you have any final comments or things you'd like to share in the conference or any particular sessions, we'd be delighted to hear them. And again, we see this as an important milestone and jumping off point for delivering and developing services for children and young people across Northern Ireland. So thank you to everyone. I hope everyone has an enjoyable evening and gets back to other work tomorrow. So thank you very much, and goodbye.
Thank you.